this conference.
They expect the hospital to be a place where
become a urologist to manage breast cancer.
I've actually lost of words because over the 3 days it was like, today it has been another historical day. Thank you.
The second World Conference on Exercise Medicine was held for 3 consecutive days, from 24th to 26 September 2018, situated at the World Heritage Site in Malaysia, Malacca. Coming to its second year, the World Conference on Exercise Medicine had received overwhelming participation. In addition to receiving support from the European Medical Association, Malaysia's Ministry of Health, the Government of Malacca and respective corporate companies, the conference gathered participation from 35 countries and more than 500 medical experts from various fields. Biologists, representatives from international medical bodies and more joined this conference.
I'm glad that this conference managed to gather 30 over delegates all over the world, and together we make the conference successful.
We are contributing our part and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide. So we believe that this complete program, which is being carried out, will bring efforts to reduce or to contain the mortality rate caused by NCD.
We are able to assemble here with a bunch of scientists, medical specialists and so forth. And we have a lot of medical doctors this year round. And I have 35 brains from 35 nations, 65 speakers in total. So basically, this is something that we hope that we can impart to all attendants here, that you can go home with some knowledge about exercise.
More to mention, Dr. Sri Jasilai had also announced a collaboration effort with the Ministry of Health by setting up its first exercise medicine clinic to promote and introduce exercise medicine in our country. Through this conference, medical experts from various fields and experiences shared their respective exercise medicine-related research reports and further discussed with the experts who were present. This 3-day conference captured more than 60 topics related to exercise medicine.
Not so many people know about aviation medicine, but it is very important in military side. They are working in a very abnormal environment. They are very normal, but they are working in abnormal environment. That's where we are.
I'm here today to talk about type 2 diabetes and specifically how exercise can improve insulin sensitivity. And we know that type 2 diabetes is a disease that stems from being insulin resistant.
I'm basically an orthopedic surgeon and I do a lot of surgeries and a lot of operations. However, the exercise medicine is also important in our everyday practice, and I can get a lot of impression, a lot of new information.
It's a really great conference. Congratulations. I present the natural lifting with exercise of elastic fibers.
I never thought that they were related together, and end up we find out that exercise is for the healthy life and breastfeeding is for the healthy life. So we are the same track. So when I come into the conference, to be honest, I think I belong here.
When there are exercises, our body responds well by producing different hormones.
So that's a mindset change. So that's why I'm saying I'm working with the mind, because we work top to bottom, right? So if you can make a change in the head, then the entire body will change.
For the future, the exercise medicine will be the new way to treat the patients.
Apart from academic research reports, presentations and exchange sessions, during the intervals the organizer planned exercise activities for all participants with the aim to get everyone to experience the integration of exercise into their lifestyles. In conjunction with the theme of exercise medicine, the organizer had also invited Malaysia's renowned artist, Fatia Latif to present the theme song of this conference, Just Keep Moving. In the closing night of the Exercise Medicine Conference, college students from Asia College of Exercise and Sports Medicine performed Malaysia's cultural dance to the guests from all over the world. In the night, the conference also announced its next World Conference on Exercise Medicine to be held from 16th to 18th of August 2019 at the Palace of the Golden Horse in Kuala Lumpur, Malaysia. It is the organizers' hopes that in the coming days, the World Conference on Exercise Medicine can continue its efforts to promote exercise medicine to benefit all folks in the world.
Welcome to the Truly Asia Malaysia and welcome to the 3rd World Conference on Exercise.
Our World Conference is to save the world. We are all here to save the world. This is our ultimate.
I want to stress that the physical fitness is more important than the body weight itself.
When we're designing exercise training programs, we need to consider the basics, the principles of training.
Very much need to be aware, if we do studies in this setting, about does it impact operability and resectability.
Prescribing exercise is not like a cookbook.
We need to consider about the concept, the causative factors, why he or she have this chronic low BP.
Contributing our parts and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide.
This is something that we hope that we can impart to all attendants here.
going to be a pleasure, right?
Become a urologist to manage breast cancer.
I'm actually lost of words because over the 3 days it was like, today it has been another historical day. Thank you.
The second World Conference on Exercise Medicine was held for 3 consecutive days, from 24th to 26th September 2018, situated at the World Heritage Site in Malaysia, Malacca. Coming to its second year, the World Conference on Exercise Medicine had received overwhelming participation. In addition to receiving support from the European Medical Association, Malaysia's Ministry of Health, the Government of Malacca and respective corporate companies, the conference gathered participation from 35 countries and more than 500 medical experts from various fields. Biologists, representatives from international medical bodies and more joined this conference.
I'm glad that this conference managed to gather 30 over delegates all over the world, and together we have made the conference successful.
We are contributing our part and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide. So we believe that this complete program, which is being carried out, will bring efforts to reduce or to contain the mortality rate caused by NCD.
We are able to assemble here with a bunch of scientists, medical specialists and so forth. And we have a lot of medical doctors this year round. And I have 35 brains from 35 nations, 65 speakers in total. So basically, this is something that we hope that we can impart to all attendants here, that you can go home with some knowledge about exercise.
More to mention, Dr. Sri Jasilai had also announced a collaboration effort with the Ministry of Health by setting up its first exercise medicine clinic to promote and introduce exercise medicine in our country. Through this conference, medical experts from various fields and experiences shared their respective exercise medicine-related research reports and further discussed with the experts who were present. This 3-day conference captured more than 60 topics related to exercise medicine.
Not so many people know about aviation medicine, but it is very important in military side. They are working in a very abnormal environment. They are very normal, but they are working in abnormal environment. That's where we are.
I'm here today to talk about type 2 diabetes and specifically how exercise can improve insulin sensitivity. And we know that type 2 diabetes is a disease that stems from being insulin resistant.
I'm basically an orthopedic surgeon, and I do a lot of surgeries and a lot of operations. However, the exercise medicine is also important in our everyday practice, and I can get a lot of impression, a lot of new information.
It's a really great conference. Congratulations. I present the natural lifting with exercise of elastic fibers.
I never thought they were related together, and end up we find out the exercise is for the healthy life and breastfeeding is for the healthy life. So we are the same track. So when I come into the conference, to be honest, I think I belong here.
When there are exercises, our body responds well by producing different hormones.
So that's a mindset change. So that's why I'm saying I'm working with the mind, because we work top to bottom, right? So if you can make a change in the head, then the entire body will change.
For the future, the exercise medicine will be the new way to treat the patients.
Apart from academic research reports, presentations and exchange sessions, during the intervals the organizer planned exercise activities for all participants with the aim to get everyone to experience the integration of exercise into their lifestyles. In conjunction with the theme of exercise medicine, the organizer had also invited Malaysia's renowned artist Fatia Latif to present the theme song of this conference, Just Keep Moving. In the closing night of the Exercise Medicine Conference, college students from Asia College of Exercise and Sports Medicine performed Malaysia's cultural dance to the guests from all over the world. In the night, the conference also announced its next World Conference on Exercise Medicine to be held from 16th to 18th of August 2019 at the Palace of the Golden Horse in Kuala Lumpur, Malaysia. It is the organizers' hopes that in the coming days, the World Conference on Exercise Medicine can continue its efforts to promote exercise medicine to benefit all folks in the world.
Welcome to the Truly Asia Malaysia and welcome to the 3rd World Conference on Exercise.
Our World Conference is to save the world. We are all here to save the world. This is our ultimate.
I want to stress that the physical fitness is more important than the body weight itself.
When we're designing exercise training programs, we need to consider the basics, the principles of training.
Very much need to be aware if we do studies in this setting about does it impact operability and resectability.
Prescribing exercise is not like a cookbook.
We need to consider about the concept, the causative factors, why he or she have this chronic low BP.
We are contributing our part and have aligned ourselves to the WHO global strategy, which is to reduce physical inactivity by 10% worldwide.
This is something that we hope that we can impart to all attendants here.
has started off the scientific program of this conference.
They expect the hospital to be a place where
become a urologist to manage breast cancer.
I'm actually lost of words because over the 3 days it was like, today it has been another historical day. Thank you.
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here we Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand.
And salam sejahtera. Okay, welcome to the second day of the WCM 2021 World Conference on Exercise Medicine. My name is Associate Professor Dr. Gary Kwan. I'm from University Science Malaysia, and I'm the chair for this afternoon first sessions. And I would like to pray, and I hope that everyone here are staying healthy, exercising, and also good advocates on healthy lifestyle. So for today, we will be enticed with a special presentations by my brother, Professor Henry Dao from the beautiful land of Philippines. Okay, let me quickly introduce Professor Henry. So Professor Henry is from the Philippine Sports Commissions, and he's the current Dean of the Philippine Sports Institute, Philippine Sports Commission. Wow. So he's the consultant of the PSC, Indigenous Peoples Games, and the former Dean of the College of Sports, Physical Educations and Recreations at the Mindanao States. So, of course, if I want to read the CV, it will take me half an hour to a full day to complete reading his CV. It's a long CV. So let me quickly pass the time to Professor Henry to give us the title, his presentation on the title, Understanding Exercise Behavior Change and Exercise Participation for Health and Fitness. So I pass to you, Professor Henry. Can you hear, Professor Henry?
Hello, can you see my slide?
Not yet. We can see your desktop only.
Are you seeing my slide now?
No, your desktop. Yes, we can see your slide now.
Yeah?
Brilliant. Yep.
Is it seen? Okay, so good afternoon to everyone. Thank you very much, Dr. Gary Kwan, for that very generous introduction. So I would like to thank the organizing committee for the invitation, and I would like to share with you my presentation entitled Understanding the Stages of Exercise Behavior Change and Exercise Participation for Health and Fitness. As we all know that we are in a pandemic, and exercise is becoming one of the most important part of our daily activity to ensure the freeing us of the possibility of contracting COVID-19 or any other illness. So my outline goes to this, the introduction, exercise for health and fitness, exercise behavior, stages of exercise behavior change, exercise participation, the recommendations, and then the conclusion. So we all know that health is wealth, that prevention is better than cure, that exercise is medicine, and we all understand the significance of physical activity and exercise to health and body functioning. At this time of pandemic, it is highlighted that physical activity as a form of exercise can truly prevent further health problems that we are encountering at this time of pandemic. So when we talk about exercise, it's not just about the following: the what, the why, the when, the how, and the what type. Most often when we are engaged in exercise, we immediately ask ourselves, what exercise program do we need? Why are we exercising? Maybe for fitness, maybe for muscle development, maybe for weight reduction, among others. And the when, we talk about the time, the availability of time we have to exercise, the how, the manner. Are we doing it at home? Are we doing it in fitness centers? Are we doing it in the community? And of course, the type. So this is a matter of understanding that when we go into exercise, we ask these questions and answer in order to start our exercise activities. And we know that there are so many recommendations being given, like we need to exercise from 150 to 300, at least 75 to 150 vigorously, among others. We need to do flexibility, aerobic, cycling, among others, that at least 60 minutes. So these are recommendations that we all are able to gather in terms of recommendation from the World Health, from the exercise professionals, and even from our physical education courses. So when we talk about exercise behavior, because this is very important, we cannot just continue exercising and forget about changing the behavior. So when we talk about exercise behavior, it is about prescribing the exercise program, wherein it is not just the giving of exercise activities or plans to benefit an individual from exercise participation. So when we say exercising for health and fitness, it is important that it is not only the activities or plans of activities that we need to go through. It does not also start from getting clearance from a medical expert, allowing individuals to participate in an exercise program. So before we go into some exercise programs, there is a need for us to consider asking our medical doctors or professionals whether we can be allowed to do some activities so that it will not harm us. It does not also start from the screening of fitness status before beginning an exercise program. So we say that when we go to a fitness center, they test us with our agility, flexibility, endurance, among others. But that's not all about going into exercise program and going into changing our behavior towards exercise. Rather, it should start by determining the stage of exercise behavior change of an individual and assessing the motivation and self-efficacy to influence exercise participation and adherence. So this is the meat of my presentation, that when we say we want to exercise, it is not just going to the exercise centers and get into the program itself, get a medical certificate, but rather start understanding at what stage of exercise behavior change we want to know about ourselves, so that we can plan a clear pathway to change our behavior towards exercising and adherence. Okay, so we need to develop efficacy, which is basically that self-confidence in our ability to make a change. So when we understand that our ability to improve our health and fitness should begin by understanding how confident are we in order to make that change. And therefore, We need to have that motivation. That is the psychological drive to engage a behavior. So motivation is a very important factor in the exercise change of any individual in order to make sure that we engage regularly in exercise. And where do we get this motivation? We can get it from the intrinsic and intrinsic factors. When we say intrinsic motivation, it comes from the internal state. Are we enjoying it? Are we getting satisfaction out of what we are doing? So by motivating ourselves, getting the desire to continue from within, because we feel that we are having fun, we feel that we are improving in the way we do things, then internally we can be motivated to continue to exercise and change the behavior from not regularly exercising to regularly exercising. Next is extrinsic motivation. This is any external factor that drives you, like support from your family, support from your friends, encouragement from people whom you look up to. And these are examples that can actually motivate individuals aside from their feeling of fun and satisfaction. So I'm presenting here the trans-theoretical model, or the stages of change model by Prochaska and Di Clemente, which explains the stages that each individual goes through in the process of behavior change towards exercise. So the trans-theoretical model, or the TTM, focuses on the decision-making of the individual and is a model of intentional change. And the TTM operates on the assumption that people do not change behaviors quickly and decisively. Rather, change in behavior, especially habitual behavior, occurs continuously through a cyclical process, which means that change is not immediate. It takes process. And it is important that we understand what are the stages of this exercise so that we can monitor the changes within us. Okay. Next, the TTM posits that individuals move through 6 stages of change. That means every individual in the exercise behavior change that we want to achieve goes through a process of change from pre-contemplation, contemplation, preparation, action, maintenance, and relapse. So these are the 6 stages that we will discuss in the succeeding slides. And for each stage of change, according to Prochaska and Di Clemente, different intervention strategies are most effective at moving the person to the next stage of change and subsequently through the model to maintenance, which is the ideal states of behavior. Which means that if we understand what stage we are in, we are able to find ways in order to make intervention or strategies to go to the next level until we reach the maintenance stage, which is the ideal behavior that we have to observe. Okay, so these are the stages of exercise behavior. There are only 5 listed because the 6th, which is the relapse, is I did not include it. So from pre-contemplation to contemplation, preparation, action, and maintenance. So these are the stages that we should know and understand so that we are able to meet the challenges for each stage. Okay, so when we talk about pre-contemplation, it is characterized by people who are sedentary. That means those who are not actually exercising because they consider exercise as a waste of time. Anyway, I'm healthy. They believe they are healthy. They are not sick. And these people do not see activity as relevant in their lives and may even discount the importance of practicality of being physically active. So they might say, well, I'm still alive and I'm not exercising, so it's okay. Anyway, I can do a lot in terms of looking for solutions if I get sick. So this is a stage where a lot of people actually are not doing anything in order to go into some form of physical activity. So pre-contemplation, sedentary, and the reason why NST is NCDs are growing because of the thought that people are actually in this situation. People are not actually getting into the idea that exercise can help not only making fit, but also improving their quality of life. So maybe you should ask, at what stage of exercise behavior change I belong? Am I in this pre-contemplation, or am I in the contemplation stage wherein people are still sedentary, however, they begin to consider the importance of activity and have begun to identify the implications of being inactive, which means that as a result of information that they are gathering, the television programs that show sedentary life in relation to healthy living, they start to consider maybe physical activity is good for me. And they are still not ready to commit to make change. But, well, I don't have time, so they make a lot of reasons. So the question is, what percentage of our populations are actually in this contemplation stage? How is the senior citizen, the adult, the youth, in relation to the states of behavior change? Are there many people at these states that we need states? They realize exercise or physical activity is important, but they still consider it lacking of time. Okay, so next is preparation. This is a marked by some physical activity, as individuals are mentally and physically preparing to adopt an activity program. Okay, so at this stage, they start to think, well, I think I need to exercise. I'm gaining so much weight. I feel slow. I easily get tired, and others. So activity during the preparation stage may be a sporadic walk or even a periodic visit to the gym, but it is inconsistent. So people here in this stage are ready to adapt and live an active lifestyle. So maybe the person or individual at this stage think that exercise really is good, and so they tried it. They go with their friends, they go for a walk, they enroll in a fitness program, but it is not consistent. Sometimes they go for exercise, sometimes they don't, but they believe that they need to be active in order to be healthy. Okay, next is the action. During this stage, people engage in regular physical activity. And for this to be maintained, they at least have to be doing this for less than 6 months. That means for a time that they were in preparation to action, that means they have been exercising at least for a certain number of months, that they gain development, improvement in the way they live, in the way they carry out their task. And of course, this begins the time when they feel satisfied with what they are doing. They have given enough time to exercise. They develop a certain pattern in terms of exercising within their home or in their work. So from this stage, we now go to what we call the maintenance stage, wherein this is what we really wanted everyone to be. This is marked by regular physical activity participation. So at this stage, you don't have to convince them. They already have a regular program for exercising, maybe 3 times a week, 4 times a week. They do it regularly and religiously, and they only need to maintain in order to make sure that they don't go back to the old habit of not exercising and gaining some weights. So this is the stages of exercise behavior change as presented by the proponents. And we need to consider that when we go to exercising, we need to understand at what stage am I in, so that I will know what to do in order to reach that maintenance stage. Okay, so these are some of the process of change that we need to consider. For those who are in the pre-contemplation, The goal is to make inactivity a relevant issue and to start thinking about being active. That means when you are in the pre-contemplation, you need to set a goal that, well, that inactivity is going to cause some. Therefore, the interventions that we need is we need to gather more information about the risk of being inactive. Okay, you may become obese, you become less strong, and etc. And of course, the benefits of being active. We need to provide information from multiple sources, either from the news, from the posters, the pamphlets, among others. And of course, we need to make inactivity a relevant issue. And that is why when we see reports that a lot of kids are obese, it is a warning that a lot of kids are not physically active. For the contemplation stage, the goal is to get involved in some type of physical activity. So you provide opportunities, ask questions, and among friends who are doing exercise, maybe consult fitness practitioners or professionals. Okay, provide information about exercise in general, because sometimes when we look at exercise, we tend to consider it as work, as tiring, and etc. Okay, so next is in the preparation. The goal is to have a regular physical activity participation. So that means the intervention should provide opportunity to be active. We set aside a time slot in a day, in a week, to be physically active, to do exercise. We provide a lot of support, feedback, and reinforcement. We make use of our to gain support in terms of how are we doing in our exercise program. Okay? And in turn, the goal is to maintain the regular activity. And of course, it is important that a continuing support and feedback is provided. Provide education for the clients in the likelihood that if you stop, you may end up getting more problems with your health, and that there is a need to continue to provide opportunity for better and healthy living. And of course, for the maintenance, we need to prevent the relapse and maintain continued activity. So a maintenance of support for friends to exercise with you, get your family to join you, provide continued education as to the barriers and benefits that you can get from exercising, and make sure that the environment is enjoyable and fun. Okay, so these are some of the process that we can go through. So when you say exercise behavior change, I have here 3 suggestions that I call 3 A's. First, we need an awareness. That's the first A. Awareness is important. Why exercise can do to my health and my life, and what are the benefits that exercise can provide to me, my family, and my community. Okay, understanding and being aware of what exercise can do for you will lead you to an appreciation, because it will give you that satisfaction that what you are doing has benefits not only to yourself, but also to your work, to your relationship, and to your community. So if we are aware of the value of exercise, the benefits, we will be able to appreciate the importance, and then we can be motivated to take action for active participation. That's my 3 A's of exercise behavior change. We need to make people aware. We need people to appreciate what they are doing, and we need people to encourage them to take action by actively participating. Okay, so when we talk about frequency, exercise participation, we talk about frequency, about regularity, the length of time, and the type. This is very important. One of the speakers in the session of community and exercise talk about FIT. Okay, frequency, intensity, time, and type. And so here, when we talk about frequency of exercise, according to Edward Losowski, frequent sessions of aerobic exercise have no clear advantage over shorter and more frequent sessions of activity. Any type of aerobic activity contributes to cardiovascular fitness. Even divided doses of activities such as a few 5 minutes walk spread throughout the day offer aerobic benefits, and accumulated activity throughout the day adds up to provide health benefits. Activity is better than none at all. But what's most important is making regular physical activity as part of our lifestyle. Okay? So regularity, how often? Exercise must be done at regular intervals and consistent. Consistency allows the body to adapt more efficiently and quickly. And ideally, exercise should be done 3 to 5 times per week. So we know that the World Health Organization has given us recommendations on how often and how long we should exercise according to practice. So the length of time, at least 150 minutes of moderate aerobic activity or 75 minutes of vigorous aerobic activity per week. Then the guidelines suggest that you spread this exercise throughout the week. You can spread it in the 7 days that you are given. Moderate aerobic activity may include activities such as brisk walking or swimming, while vigorous aerobic activity may include activities such as running. Strength training exercises for all muscles groups at least 2 times a week as recommended by World Health Organization. So for the type of exercise, we have flexibility, we have aerobic and anaerobic. So these are examples of exercise activities that we can go through in order to develop our health and fitness. So when we talk about behavior change and exercise participation for fitness and health, Lamorte in 2019 concluded that the trans-theoretical model provides suggested strategies for stages of the decision making, which means the value of understanding what stage are we in will help us decide on what activities or intervention we need to implement. Okay, this can also result in interventions that are tailored for us, for the target population, according to the level of knowledge and motivation to become effective. So, and knowing what stage we are in when we get into the exercise program will help us understand what needs to be done and how we can motivate to address that level and improve to the maintenance. The TTM encourages an assessment of an individual's current stage of change and account for relapse so that we can make effective decision-making process. So what we are actually asked here is, if we want to exercise, use exercise as a form of medicine for health promotion, we just don't go directly to exercising, doing the physical activity. It is important that we first assess at what stage of exercise behavior am I in so that we can plan accordingly. Okay, so for the recommendation, first, we need to start by determining the stage of exercise behavior change of an individual and assess the motivation and self so that influence participation and adherence. So here we have stage of change, level of motivation, and efficacy as vital component of providing exercise programs. Second, we need to determine what stage a client is currently in and establish appropriate goals to identify relevant behavior change that can help the client to progress from one level or one stage to the other. Finally, regular exercise is key in staying healthy and fit for life. So the idea that if we want individuals or communities to participate in an exercise program, we should not only focus on giving them the program, the activities, but we should start by understanding and making them understand that we need to know first what stage of exercise behavior am I presently in so that the plan of changes can be made effectively. Okay, so I'm not sure if the exercise professionals are actually assessing the stages of exercise before they recommend exercise programs, but I believe it is important that prior to providing exercise activities is the identification of what stage the individual is in terms of exercise behavior change. With that, I say thank you very much, and I hope that we will be able to know what stage we are in now so that we can plan our exercise program effectively so that we will have a better chance of progressing from one level to the other and be able to achieve maintenance states and stick to the program as part of our healthy living. So thank you very much for your time, for your listening, and I look forward that we will continue to spread the good news of exercise medicine as a way of promoting healthy lifestyle, fitness, and quality of life, not only to combat the pandemic we are in, but also to make sure that our community is part of a growing practitioners of exercise in our respective countries. Thank you very much and good day.
Wow. Thank you, Professor Henry, for the inspiring lecture on the stages of change. Maybe let's us open for Q&A.
Yeah.
Okay, just a quick Q&A here. We have one. Okay, so Professor Henry, if a person perform exercise to escape from COVID-19, is intrinsic or extrinsic motivation?
Pardon? Is
so if a person perform exercise to escape from this COVID-19, is it more intrinsic or extrinsic motivation? Wow.
Yeah, actually, everything should begin within. Okay. Yeah. When we talk about starting anything, doing anything, it should come from within, the idea of starting it, because we understand it, we value it, and therefore, if we understand, we value, then the initiative of doing it is longer lasting because the motivation is coming intrinsically. The extrinsic motivation is just a support service that we can get. First, you have to show interest. Your friends can enhance your interest by giving you feedback and by motivating you further. But basically, when we talk about the pandemic, your friends cannot push you to exercise if you yourself will not start exercising and accept the idea that exercise is important to you. So I believe that in everything that we do, what we are accomplishing will be more lasting and more important if the desire to do it is from within. It all begins within us. Nobody, like, you cannot allow an elephant to drink water if he is not thirsty. Okay, so that's an example. We need to start from within, and the extrinsic motivation can come in like appreciation from your friends, improvement of your body condition, among others. But to move, it should start from you. I hope I answered the question.
Yes, totally agree. I agree with you, Prof. Henry. Another question. So should we ask a client to exercise first, or should we actually change their behavior before they exercise?
Okay. Maybe there's some misunderstanding. When I say prior to exercising, it is best that we know what stage we are in. That's very important. So we need to understand, okay, I want to exercise now. If I'm not exercising and I decided, oh, exercise is good because my neighbor is getting better, healthy, etc. So I want to start. What is important is first assess at what stage of exercise behavior we are in. Am I in the contemplation? Am I in the contemplation? Am I in the preparation? Because knowing that will give you a better roadmap to pursue exercise in order to reach the ultimate stage, which is maintenance. But if you just go there, okay, I need exercise, and then go immediately play, etc., maybe tomorrow you get tired. Maybe tomorrow you don't like it anymore because it is an inconvenient. But if you know the stage, you can plan how to approach your exercise program.
Okay, brilliant. I think I will stop the Q&A now, so we will able to continue the next session. But I just have a quick announcement by Professor Dr. Muhammad Lee, Prof. Lee. The announcement is that we have received the recording from the Honorary Azalina Othman on the title, Global Aging Population, Staying Healthy and Maintaining Relevance, and it will be aired at 4 p.m. today, 4 p.m. today. So stay tuned at 4 p.m. by the presentation by the Honorary Azalina Othman Said. Okay, so now I'd like to pass the baton to the next chair, Ms. Yu Sufan. So I will pass it to you. Okay.
Thank you very much, Professor Henry, for chairing the first session. And welcome everybody. I'm going to chair the next few sessions. So my next speaker is Dr. Ian. Wait, sorry. So the next speaker is Professor Dr. Domenico Cipriano. He is from Italy. He is going to speak on heart disease, digital technology, and exercise. He is a cardiologist by profession, and he is also a professor in cardiology medicine, member of the advisory board on the Cardiovascular Rehabilitation American Heart Association, and he is also the director of Cardiovascular Rehabilitation San Raffaele University and Hospital in Milano, Italy. Very, very long designation. Welcome, Professor Doctor. We won't take up much of your time, so continue your session.
Hello, good morning, good afternoon, everyone, wherever you are. Thank you for the introduction, Ms. Yu, Shufan, dear friend. It's nice to see you again at a distance. And it's a great pleasure to be connected with these very interesting and motivated and committed group of friends since the latest 3 years.
Thank you.
What we're going to talk is focusing mostly on the evolution on the digital arena in the cardiovascular space. And I wish to remind everyone that later on there will be a heart disease and exercise session, which have 3 very interesting lectures. One is the natural follow-up of yesterday's and today's sessions on motivation and health literacy, and we will be happy to host Dr. Dan from the American Heart Association. Also, just after him, there will be a session presented, a presentation given by Professor Hansen, which is a board on the European Association of Preventive Cardiology. And last but not least, my colleague and friend, Dr. Maranto from Italy, with an issue: is my patient too frail to exercise? So we will focus now on all the aspects of digital technology. So with a little help from our friends at the okay, I'm trying to share my screen. I'm coming up in a second. There it is. Sorry for this kind of delay. Too many screen too. You should be able to see now. Okay, the presentation, is that right? Okay, thank you. You had the introduction, and just a few days ago, I encountered a blog in the Malaysian sites with a letter of a couple of individuals asking and wondering if the use of digital technology to prevent cardiovascular disease was enough. They underline two key issues. One, even in Malaysia, the World Heart Day from the World Heart Federation, where they highlighted the adoption of digital technology to prevent and control cardiovascular disease. And they have this nice logo for all the actions to act on better than exercise than to act on obesity. But let's go back to the heart. Very well, see sort of dose response pattern of physical activity and the reduction of risk of cardiovascular disease and other disease, and follow up all standard recommended equivalent of 150 per week, and the effect is progressive with the increase of leisure time physical activity. So it has to be as the motivational issues that we heard from Professor Dodd earlier. It must be something that people are willing and desiring to produce regularly, and some other people that cannot do it, they don't have time or not motivated yet. So can non-physical activity be beneficial on the health? Reduce even that activity just benefit is starting. If we read the cardiology, we think of the heart, but I would like to underline briefly that physical activity has a very important effect on the vascular system by a means of several mediators in a conundrum imbricating also metabolic disease. Okay, I have a request from the management team to check the connection. Is the fastest I have right now. I can switch eventually my camera off to save on bandwidth, if you agree. So you see the slides only and hear my voice. Okay, meaning through the activation of nitric oxide, vasodilator prostanoids, antioxidant, and so having a better peripheral circulation will ease the effect and the work of the heart in prospective terms, and more importantly, in secondary prevention, all the exercise that needs to be done after the an acute event like myocardial infarction or heart failure or whatever. That there is the usual question again, how many steps per day are enough? And we are dealing with a large range of people, also older adults and special population. And it means in the line that a little activity is better than none, that even 3,000 steps per day could be beneficial. So we have a first item. Any physical activity is good. The more, the better. Now let's enter the digital arena. Cardiologists have been challenged by innovation through the latest 20 years, I would say, and the impact of all the evolving digital tools has been very helpful. This is a meta-analysis, very nice, showing that the use of digital tools could improve the outcomes, could improve participation, could improve the benefits we're searching. There is a catch. This is a paper published last October. Most of the as a result, reducing and modifying risk factors in patients with the coronary disease is this large randomized clinic published on JAMA. And these are some of the examples. I won't take too much of your time over here, but I'll just show a couple of messages that get through. A high, whatever the name of the person is, don't forget physical activity, or remember to quit smoking, and so on. Let's see the results briefly. As you can see, of the participants, the largest majority, almost all of them, found the messages useful, motivated change, read at least 3/4 of a message, and eventually they improved all the targets, which is exercising regularly, twice as much as the people, and in increasing and very significant increase in the number of people that reduce blood pressure, cholesterol, stop smoking, reduce their weight. So we go back to the first lesson of this morning, which was motivational. Anything we can do is good. Another tool that has been around for a long time was the web. There were several examples of using the web approach. We know the web is not that pervasive as we have now with the mobile phones, but the key point is this is an Italian group that used a system in which a nurse, text messages and web were used to do training, home-based, so people that they were not attending exercise sessions in a closed environment. The results are very good. You can see the percentage of compliance is very high in most of the activity, and the white bars on the left part of the screen show that the achieving the target in secondary prevention, like stopping smoking, having lower cholesterol, lower blood pressure, losing weight, was better in the people that were connected to something. So the key word, the buzzword is connecting, whatever the means is, face-to-face, text, web, and we see the rest. The digital intervention for risk factors, whenever you go and see the literature, you see once again the most are automated text messages. There is a sort of online education, but the most effect is coaching. In this activity, unfortunately, there was not a great effort in studying and adopting behavior change techniques like we heard today. This is a Dutch trial of a few years ago, and the message of the screen here, okay, do you remember to go playing football? Please check your calendar of activity. Any of these trials show some sort of benefit. So once again, the key is exercising. But then we're moving toward the usage of mobile health intervention with or without devices. Once again, these are very useful to promote, very useful to monitor the kind of activity. So the other key point, we cannot let devices alone, but we need guidance. And as far as digital tools are concerned, this is a nice review of all the present and upcoming devices. This is very recent, as you see, January this year, into the different area in which we are interested today: physical activities, weight loss, diabetes, smoking cessation, hypertension, and so on. And it gives a perspective of the evolution. Given a perspective of the evolution, the shift toward the attention has been moving toward the approach in building behavioral change, which are not yet that strong in all the studies that do demonstrate effects. So the key point, once again, is use technology, the most available technology for the people you're facing, and try to connect and evaluate the outcomes. And then comes the wearables that have been disseminated from a sort of commercial pressure. And we know that they impact positively physical health in people that do have mostly the need of, for instance, cardiometabolic disease. Once again, devices came around from a different target, monitoring physical activity for the healthy, for the athletes, and so on. So the focus in the cardiovascular space came afterwards. I would say they were a solution in search of a problem. Now we have the problem and we have the tools to achieve the perfect solution. It's the combination of mixing and matching people and devices that will be very effective. But monitoring physical activity has been a long-standing effort. Some 10 years ago, using accelerometer, some of them were bulky, there were not that very much dissemination, and assessing the level of activity in adults and older people gave, and this is the Northern European countries, so our friends from the countries can comment in their lectures in these days of the conference. What came out is that approximately 1/5 or only 1/4 of the people were exercising in a useful way, 30 minutes per day or 10,000 steps. So very lower than the threshold. Using step counters has been demonstrated useful. A nurse, so again, the combination between person and technology was effective following recommendation, and for instance, from the recommendation from the European Association of Cardiovascular Prevention and Rehabilitation, and once again, we'll have Professor Hansen later today, demonstrated that over time, this is a year, the level of activity, if you get a clue what you're doing and you provide feedback of improving, you achieve greatest results. But let's try to see how these devices do provide feedback and try to substitute the person. And I once again underline technology plus people. This is very nice. This is some years ago where the initial devices came around. Now the market changed, some companies merged, some companies disappeared, were integrated into new, but these were the typical bracelet. And these researchers went through all the features of the different devices, mostly on goal setting and feedback on behavior and self-motivation. This is a nice paper with plenty of examples to which we can gather what is the focus that we can give patient into checking the several features that devices are providing, as far as the activity plan is concerned, as far as the commitment, as far in feedback on behavior, or the outcome of the behavior, or moreover, the support for social communicating. We have experienced, every one of us in this arena, that everyone starting exercising, communicating with people and friends will involve other people. It's a sort of member get member in this virtuous circle which is exercising. Social support is very important because this is an additional tool where isolation is present. And beware, most of the isolation is urban isolation because communication in cities is much more difficult than in smaller communities. So this is a tool that you can try to promote in your exercise clinic, having people talk, having people sharing the results of their exercise activity. This is a nice commentary. Wearables for cardiac monitoring in the high end of people exercising, the athletes. It is good, it is bad, it's just a marketing thing because that's where it all started. And I invite you to read it because it is interesting because athletes do have a coach. So we need to be the coaches of our patients or our people in order to avoid for them to become patients. The interest and the evolution of this technology also involved the major scientific societies. This is the American Heart Association that tries to put some key points into the definition of items, what is e-health, what is m-health, what is a wearable technology, and the features compared as a smartwatch or mobile integrated therapy, the convergence of mobile technology, clinical and behavioral science, and scientifically validated outcomes, because the risk is still, once again, the solution in search of a problem. It's only the integration of everything that is the key to success. And the examples of this integration are in this nice chart in which the evolution is next, the so-called Internet of Things. So anything is connected, and so we have possibly different devices that eventually have to go to data analysis, data interpretation beyond what is the capability of the machine and provide feedback, patient notification. The person, the key, the exercise therapist, the behavior counselor are the key to success. And we need this success to reduce the incidence of non-communicable disease. Let's shed some light on a couple of important issues. And this is a review on Nature Reviews, one of the most important set of journals on the planet. Smart wearable devices in cardiovascular care, where we are, how to move forward. And they provide some key points and a sort of ABCD guide for clinician and person involved in managing and promoting physical activity. The key points are, first of all these devices produce more data than we're currently able to process. So we have to try to stick to what we know and then try to increase our knowledge into the potential of the devices. Check the evidence for these devices and the kind of parameter we're measuring. There are several challenges. Overcoming these challenges means that lots of people have to work together to get a framework of operation, and scientific societies and group like this one, like the World Conference on Exercise Medicine, can effectively do this. The ABCD, we can go quickly, are assess what the device that you're proposing or the person in front of you saying is using, access the reference data for this, because you need to know if this is reliable. Check the benefits, see, make an integration in the workflow. So an exercise clinic, the patient has a device, try to set a standard for getting the data back. And last but not least, check with the patient or check yourself where the data are stored and which are the privacy regulations. And if the company collecting the data will share these personal data to anyone else or will sell the data, worse. The approach moving outside the hospital in cardiology, in home-based mobile intervention, has been reaching the most innovating technology in curing heart disease. For instance, this is the transcatheter aortic valve replacement. But let's say the conclusion of this home intervention. Rely on technical advancement, also on better patient education. So people are in the center. Let's use a compass for like the latest few minutes for quick steps into the evolution and what the strategies that came with the COVID pandemic. This is a nice tutorial, and there are 6 stages. Consult, adapt the procedure and materials to a research protocol. Whatever you do, record and analyze the data. Do some testing of the process that you have, streamline the procedures, and try to have also feedback at the end of treatment, a follow-up strategy. And moving towards exercise, well, there is a new word, rehabilitation and prehabilitation. So exercising before a cardiac intervention, which has been proven very useful in people on the waiting list for cardiac surgery. But now with over 4.5 billion smartphones, people can measure their activity and use the standard 6 minutes walk test as an outcome measure, which is the standard yet. Probably is not all, but this is useful, can be repeated. So whatever the device, try to get the most reliable data. Teach the patient to do the 6 minutes and check it over time. Yes, we know the future is not just 6 minutes walk test. There are plenty of new parameters that we can understand measuring, and we can do it. This is a sort of uphill road, and we don't know what will happen next. We could be scared of what could happen next. But there are some guidelines also from the working group of the European Society in Cardiology that prepared a specific document for the use of available wearable technology. But I want to underline the gaps in knowledge. The gaps in knowledge is to maintain engagement in greater than 3 or 6 months. You have the new gadget and then you forget to use it. Again, technology is also, and mostly after the pandemic exploded, through social media, also highlighting global cardiovascular disparities. And the use of social media could be useful if guided, not useful if it starts disseminating, we know very well with the COVID pandemic, fake health news. And I wish to conclude with the message from the World Heart Federation, which is emblematic to us: cardiovascular health for everyone, exercising since you were young. Thank you for your attention. I'll turn my camera on.
Right. Thank you, Professor Dr. Domenico, for your very interesting talk. And I know you have a lot to share. You're like so busy, but time does not allow you to put across as much as you wanted to. But thank you very much for your very interesting presentation. And I know that AI has now made our life so much easier. With IT, we are able to do a lot of things from home, and even we can now monitor patients' performance at home, right? So is there any question that is burning and you would like to put forward to Dr. Domenico? Is there any question?
While questions are coming for the last minute, I would say, okay, AI is another issue. For the sake of time, I did not include AI in the technology with the benefits and the risk of AI according to who is getting the data and who is processing them. So once again, people are the key. And some of these items will be discussed later today in the heart session.
Yeah, since there is no question, I would like to put one question to you. We noticed that even with the smartphone, there are a lot of things being put in there. They even teach you how to do even specialized techniques, which is supposed to be done by a physician or a qualified technician. Like, for example, I do vestibular rehab, so I just bring up vestibular rehab. They just teach you how to put the phone on your forehead and how to turn whichever angle. I would like to ask you, is there any risk or any dangers in using this kind of technology that is put forward to our community, to the public? Is it dangerous? Is it all right?
The only danger is not a technical danger for the device itself or the emission of waves and so on, because after more than 30 years of mobile communication, we can say we're pretty safe. The real danger is where your data end up. There is a widespread habit of putting your health data into WhatsApp for communicating with physicians and health professionals. These data end up in Facebook and they are automatically shared. And Facebook says that even if there is a data breach, does not have the need to communicate to people. So putting relevant clinical personal health data into social media, not in a one-to-one communication, could be dangerous, and new regulations need to be kept in place.
All right. Thank you very much for your answer. And I hope everyone listening in, just be careful on where you put your data, because it could be viewed by many people if it is not carefully done, right? Since there is no data, thank you again, Professor, Doctor. It is a pleasure to see you after such a long time. Okay, and thank you again.
Okay, see you later then. Thank you.
All right, like I said, he has so much to share with us, but time is short. So we would like to go to the next speaker, and he is Dr. Ng Ye Ying. I don't know how to pronounce his name, Dr. Ng Ye Ying, okay? He is from the Minister of Home Affairs, Singapore. He is currently working in emergency and public health, physician with Tan Tock Seng Hospital. He concurrently is serving as Home Team Chief Medical Officer, Ministry of Health. He is also the Deputy Clinical Director of Ng Tei Fong Center for Health Innovation. Welcome, Dr. Ng from Singapore. You can start your talk.
Hi, good afternoon. My name is Dr. Ng Ying, and I'm going to talk about the importance of AEDs in the community. I work as the Chief Medical Officer for the Ministry of Home Affairs Singapore, as well as a Senior Consultant Emergency Physician at Tan Tock Seng Hospital. So as we all know, CPR and AED is very key to survival. And when you look at the chain of survival, a lot of it is actually with the lay rescuers. So if you look at the first 3 rings of the chain, right, a lot of it is in where lay persons are and where the community is. This is a slide and a very old study from Seattle, King County, Seattle, where they actually looked at time it takes for people to start CPR as well as time to deliver the first shock with an AED. So what they found was this, that there is a matrix relationship between survival and the time to start CPR as well as time to shock. So typically, right, in many systems, the time it takes to start CPR can be as long as 9-10 minutes, and the time to get an AED is even longer. So survival in many communities are actually really close to 0. So how do you improve on this? One of the things that we've found out, right, was the advent of telephone assisted CPR or dispatch assisted CPR. In Singapore, the number to call is 995. So by calling 995, the dispatcher actually offers telephone advice and coaching people with just-in-time instructions to do CPR. This way, you can get the CPR time down to literally 0 to 4 minutes. And after that, of course, being able to bring the AED in as soon as possible makes a huge difference to survival, as you can see. Okay, so for us, right, we started a journey of telephone-assisted CPR in the 995 Center with a lot of coaching of the call takers, role-playing, listening to the recorded calls, and debriefing through the recorded calls itself. And we also had a standardized telephone CPR training workshop for the call center. This was the international course that we ran with foreign participants from around the region. I think there were doctors, dispatchers, paramedics from Malaysia, from Thailand, from Japan, as you can see in the picture. The program is actually fairly simple. It's a one-day workshop where people are coached, and they practice how to deliver a standardized script, following a protocol so that they are able to deliver this in a very, very quality controlled manner. So we've even published the results of what we've done before and after intervention, and this is what it shows. If you look at people who started CPR, by themselves, the natural rate in Singapore seems to be about 20%. But when we actually dive into the details, right, we find out that actually there are more people that know how to do it, but they don't dare to start, either because they're unsure there's cardiac arrest or they're unsure of the skills. So the ones who really are coached, right, because they absolutely don't know CPR and then they are asked to do it even though they've never trained before, it's actually a small percent. So just having a dispatcher help to diagnose and just guide someone through the initial stages, right, it's actually very important and very useful. So just knowing the skills of CPR itself, right, it's really not the same as being able to do it in an actual situation. So it's something that we realize as well, and we'll talk about that. So in Singapore, right, actually a decade ago, our CPR rates were actually very, very stagnant. When we started this telephone assisted program, right, you can see the numbers actually jumping from 20% to 30, 40, 50. Now in Singapore, the bystander CPR rates is almost 60% because of all this telephone assisted coaching. So this is a video, right, of an actual incident where this gentleman, he was actually at the beef noodle shop, and he heard the chef at the back collapse. They called 995, and then he was coached over the phone how to do CPR. And as you can see him doing it, and the paramedic taking over. Unfortunately, in this case, our paramedic, I think, was a little bit too fast, yeah. But anyway, I mean, this was actually a good story. They transitioned over to a mechanical CPR device. They transported him, and he actually spent a month at SGH, Singapore General Hospital. So the nice upside to this was that Edwin, the Good Samaritan, right, was offered a lifetime supply of beef noodles at the shop. Yeah, so I'd like to introduce to you this thing that we have actually developed after, some years of experience from, learning more about what happens in a cardiac arrest situation. So listening to many of the calls, where we recognize that some of the challenges that we face, through our programs that we've led, is that very often people don't really know what to do. You may have been trained in CPR, but the conventional trainings actually don't teach you how to deal with the situation. So we modified and created a simpler program called the DARE program, which is the Dispatcher Assisted First Response Program. So it teaches three simple things. One is to remind people what number to call. Two is to show them how to use the AED. And the third one is to simplify to a hands-only CPR program. So what we found out actually through surveys that we've done, right, was that actually, right, 20% of the population still don't know that, this 995 is for ambulances. A lot of them think it's only for fire, because I think the fire department has very good branding and very, very good communications. Even though it's fire and EMS, the same number is used for both. But a lot of people, there's still a significant number of people who don't know that. Second one is that there's still a lot of confusion, right? And there are a lot of people who do not believe that they can use an AED, even though it's meant for laypersons. And the third one is that, as you already saw in the earlier part, that only 20% started CPR by themselves. So there are a lot of postulates and a lot of theories why people don't know 995, even though it's supposed to be a universal number, right? In the old days, right, we used to have coin phones, right, public phones, and on the public phone they always have these little things here. But nowadays, right, there are no public phones because why everyone is on a mobile phone. But in the old days, when you dial on a public phone, you will see that 999 is for police in Singapore and 995 is for fire and ambulance. So we proceeded down this path of creating a simpler program called the DARE program. We've actually have nationalized this, so it's out in all the schools. This is our previous Minister of Health, showing the program. And we've actually shortened the program from a 4-hour training to a 40-minute program. We've also introduced some of these elements into the syllabus, right, as civics classes about, under exercise and healthy living. So we introduced some of these concepts for kids at 11 years old. And so this is a public event that we held. This is one of our doctors, Dr. Jade. This is one of our ex-ministers. And we introduced the program so that it's very approachable and very friendly for young kids as well. So at secondary 1, the kids are given hands-on, and this is a class program run with 40 people as well as 4 instructors. So we tend to have a better ratio of 1 instructor to 10 students because the program is simplified and it's 40 minutes. Why 40 minutes? Because that's a typical class period in a school. So this is a very efficient, time and resource efficient program.
Today we're going to learn all about cardiopulmonary resuscitation. Everyone can do it if you dare.
Call 995. Stay on the line.
A medical dispatcher will instruct you. Start CPR. Interlock your hands and push.
Push hard and push fast.
Get an AED. Continue to push hard and fast while you wait for the ambulance to arrive. So I suppose you're tougher and more daring now. Goodbye.
Yeah, so this is a program that we sponsor as Ministry of Health. And as you can see, it's made in a very approachable fashion, and it's part of the teaching video for the kids. The video itself is 15 minutes to 25 minutes of hands-on, making the 40-minute program. So what's special about the DARE program, right, is that we focus on the very practical parts of a cardiac arrest situation and what they would do. So one is it that we also included the recognition of agonal breathing so that when people see it, right, they don't think that the person is alive and awake, that the person actually needs CPR. The second one is to teach people how to interact with the dispatch. And we actually included the dispatcher in the video itself. So this is part of the revamp of the Singapore Resuscitation and First Aid Council. We actually included this teaching of agonal breathing since 2018 so that people recognize that, agonal breathing is actually a rest state. And you can see that this is what it looks like. It's very, very slow type of breathing, gasping type of sensation. So we put it in as a teaching video so the CPR training centers can use it for teaching itself as well. And this is one of these things we recognize that a lot of lay persons actually hesitate to start CPR because when they see the agonal breathing, they think the person is okay. So they stop CPR actually. And the last thing that we've done is that we've actually modified the CPR training program to cater for hands-only CPR for lay persons. Okay, so now on to the meat of the things, right? Public access defibrillation. So this is the other half of the talk. One thing that we recognized was that 10 years ago, our usage of AED rates was actually really quite low, 1.8%. And that was something that is actually fairly dismal. We know that we can do better, and we actually have proceeded to look at the whole thing from a systems perspective to see how we can improve it. So we started mapping out AED locations. We looked at the cardiac arrest situation and where the AEDs are, and clearly that there is a gap in quite a few of the cases. So when we mapped out, right, what we realized is that in terms of cardiac arrest, the majority is in housing areas, and followed by vehicles, medical facilities, and offices, shopping malls, for example. So I know this is on exercise medicine. Sports facility is actually less than 2%, but I mean it also represents a very important 1.6% in this case, because the people who play sports are actually very healthy, right? And actually there's a huge economic loss for people who are playing sports and suddenly having cardiac arrest. So one of the things that we did, right, was that we tried to address this huge gap of cardiac arrest in housing areas, because in Singapore, a lot of people stay in high-rise buildings. And in fact, 70% of the cardiac arrest happens in the public housing estates. So we actually initiated a program of putting one AED in every 2 blocks. So this has actually been done already. It's been around for about 3 to 4 years, I believe. This was some of the first installation. This is our then DPM Teo Chee Hian. Yeah, so this is a typical AED, next to the lift lobby, and these are very nice signages to show you like where the AED is. So this block doesn't have an AED, but the block next to it has the AED. So the signages show that. We also started a registry for the AED so that we can manage it, because one of the challenges is that AEDs, if you plant them, right, you don't take care of them, eventually it runs into trouble, because these things have batteries, these things have pads that expire after a while, so they do need very active maintenance. So this is the Singapore Heart Foundation. They actually help us do this job of checking the AEDs as part of the foundation work. So they put in the stickers so that people can put maintenance information, and they put in the decals so that we know when is the next servicing or when is it due. They also created an AED guide for building owners and AED owners so that they know what they need to do. And this is what they do to register. They collect the data on the AED model numbers and the locations, the expiry dates, so we put this information with all the AED boxes so that all the AEDs that are publicly registered will have this information under a single registry. So what we found out in the first year of doing this in 2015, right, was that almost 13% of the AEDs had some sort of issue. That means either the batteries were expired, the pads were expired, there was no clear maintenance, or it's been a few years since they were maintained regularly. So after initial registration, we notified owners as well so that they were aware, and in the subsequent years after that, right, even as the numbers of AEDs continue to increase, the percentage of AEDs that have servicing problems continue to stay below 1%. So I think this is very positive for us. So this is just an example of the AED locations. We can find it in open source onemap.sg, and it's also mapped into the 995 call center. So we also, together with the Heart Foundation, we ran surveys as well. So we asked about like how many people or what percentage of the population knows how to use an AED, whether people recognize the AED sign. We can see that the numbers are actually going up. In terms of asking people whether anyone can use an AED, the numbers have gone up with education, and asking people about whether they are confident to use the AED. As you can see, the efforts for advertising the public and giving them the right information has helped. So these are some of the things that we've done, things like road shows in the community about, we ran it as the Save a Life campaign between the Singapore Civil Defence Force and the Singapore Heart Foundation. So some of these programs have been very useful in terms of informing the public and normalizing some of these ideas about using an AED. So the last few things I think probably important to say is this, right? Where should you cite an AED? Typically when you look at risk, right, it's really all about the frequency of the event, and then multiplied by the probability. So when you think of it in those dimensions, right, shopping malls have a lot of people, schools, workplaces, so those large places, right? The potential frequency is higher, right? Because you have more people at risk. Where there are people who are vulnerable, let's say things like nursing homes, hospitals, places where, you know, there are large numbers of people who are elderly. So elder daycare centers, community centers, for example. So those are places that may be worth considering putting an AED. The third one is, of course, with the theme of this conference, it's about exercise medicine. So sports itself, cardiovascular activities, right? High cardiovascular activities, of course, temporarily generate cardiovascular risk. So, of course, sports facilities will be the other clear indication for putting an AED. And of course, when we consider the other part is the economic cost, because in terms of, let's say, sports, right, this is very important because young people playing sports, they actually have a very long potential lifespan, and you know, cut short by a cardiac arrest is a huge economic loss. So I think for those reasons, sports facilities also, it's very, very important. Okay, so I think this is really a very quick overview about the importance of AEDs and you know, how to implement a program and where to put the AEDs. And this is my last slide. This is Singapore's own data about the public access defibrillation rate. So since we started in 2011, we had 1.8% of usage for AEDs in all situations. And you can see that this has actually gradually risen with the many initiatives that we have put in with community training, AED placement. We actually have a mobile app as well. But don't have time to cover that. But it's called the My Responder mobile app. Feel free to Google it. It's actually quite a nice, very nifty app which puts in all the AED information as well. So with the rising of bystander CPR rates, with the increase of AED usage, you can see that actually, right, this is the annual number of survivors. We do see a very nice uptrend over the years. So definitely AED plays a very big part in that. Okay, so this is all I have to share about the importance of AED in the community. I hope this information is helpful. If you have any further questions, please feel free to email me at my Tan Tock Seng email, or you can look me up on LinkedIn. Just Google my name. You should be able to find me, and then just drop me a question, or just link up to say hi. I'll be happy to catch up. Thank you very much for your time. Sufan, I think you are muted.
All right. Thank you very much, Dr. Ng, for your very, very interesting talk. And I'm sure many of us would like to applaud you for your success in implementing AED in the community. And I'm especially impressed on how the young children are now able to do CPR. That is really a great success, and implementation of defib in a community. So really is an eye-opening for many of us. Now, there is a question for you from Mandy Koo. She would like to know, how long should it take to get an AED to achieve good outcome? Any special consideration when public use AED? Okay.
Typically, we try to, in terms of citing AEDs, right, we try to have a 4-minute distance, with a fast walk or run. So the other consideration, of course, in terms of cost effectiveness is that, if you put the AED in somewhere which is very rural, right, like let's say a jungle, or let's say a cycling track where, the distances and people, there are not a lot of people, it's not cost effective. So we tend to focus on two things. One is that places with a lot of people, some places use an arbitrary guideline of about 500 people and above. It's worth putting an AED. The other guideline that they put is to use a distance of about 4 minutes to retrieve an AED, 3 to 4 minutes, because we know that when you look at cardiac arrest, right, brain death will start in about 4 minutes. So they use this as a rough guideline. So if the collapse happens, you run to the AED, you come back within 4 minutes, you shock the patient. That's supposed to be ideal, but we do recognize that there may be other things like cost factors, the ability to maintain an AED in a particular place. Then we may not be able to always put an AED where we want to. The last couple of thoughts with this, right, is that we also look at risk. Places where there are people always at risk, right? Let's say you go to a gym where there are a lot of people exercising. That's one. Another one is places where people, have heart disease, right, or chronic illnesses. So nursing homes, clinics, hospitals, or maybe the grounds of a hospital where there are a lot of people gathering. And these are the sort of places that also would suggest that it might be worth putting an AED. The last thing you can consider is look at the data. If you have a national AED, or sorry, not national cardiac arrest registry, we have a registry of cardiac arrest that we map out annually. So based on the data, we can also see what places seems to have a congregation of cardiac arrest cases. So from there, we can actually see the gaps, right, where there's no AED coverage. So based on that, you can use an evidence-based approach to also look at where might be a good place to plant AEDs to improve that coverage.
Okay, thank you, Dr. Ng and Ms. Mandy Koo. I hope Dr. Ng has answered your question. Now we have got the next question, and we hope it will be brief. It is from Rosni Saleh. What do you advise or recommend the use of AED for outdoor sports, for example, jungle trekking?
Wow. Okay, that's a tough one, because I would say that in places like this, right, because when you deal with cardiac arrest, it's really a whole system of care. So just having an AED alone is really not effective, because even if you can shock a person, right, the chances of them coming back, is probably maybe about half or so. And if you can't bring him back, you do CPR, but you can't evacuate the patient. So I think in these cases, or honestly, the prevention side is probably more important, making sure people are screened, you have progressive exercise and they are prepared for the exercise. Having a cardiac arrest in the jungle, right, honestly, survival rate is really going to be very dismal, because unless you can helicopter in, your response times are incredible. Most of the time, I don't think it's feasible.
All right, thank you, Rose. Your answer is very difficult, yeah? So thank you again, Dr. Ng, for your very, very interesting talk. So we will move on to the next speaker.
Thank you.
All right, our next speaker is Professor Dr. G.L. Khanna. He is from the National Sports University Ministry. Manav Ranchana International Institute of Research and Studies, member Prime Minister Olympic Task Force 2024 to 2028. He is also the president of BRICS, Council of Exercise and Sports Science. So Professor, welcome, and you can begin your talk.
Hello. Thank you very much for your encourage. I just want to, I'm just sharing the screen. I hope you can see my screen. Can you see my screen? Hello?
Yes.
Is it shared?
Okay. Yeah, it can be seen.
Just a minute, I'm not getting full screen. So good afternoon, everyone. I'm really happy to be a part of this World Conference, And it's good to thank you very much for giving me this opportunity to have interaction with you, particularly in this COVID session. You know, the COVID is still is affecting us, and I would like to share certain things about the COVID only. That what are the exercises for body immunity during COVID-19 pandemic? That what kind of work has been done and how it has affected us also. This we know that it was just a beginning here in the 2019 onward, and the pandemic has taken a big created a big problem for all of us, and the first wave has created more problem for various older people, and second wave for all age group comorbidities were there in this, and particularly various systems which were affected was, of course, we all know now, we have enough now awareness about that the respiratory system comprises of and also immune system exacerbation of the underlying medical condition, and eventually systematic failure, and also somehow the fatality also occurred in few. So this one was a big challenge for all of us, and still it's ongoing challenges also. Whereas we are more concerned about this, that the problem is that we were not able to even exercise also. If we see the data is a huge data, and billions of people were affected in that, now also it's going on, and number of deaths also which is now recorded. And the vaccine which has come up recently, maybe in the last 6 months onward, the vaccine doses have been given, and even more than 1 crore we have been able to get it in this. 100 crores we have been able to do in India also. So it was the cases where, as India is concerned, the second wave has given us really a big challenge, and a huge number of this population was affected in this. If we even compare with the US, we had more number of people which were affected by April. And then after that, it was a little bit slowed down, but still the cases are going on. The COVID-19 was, the fatality rate, if we see, has gone really it was a big challenge later on. And if you see the comparatively, the various countries have been affected, whereas England and Netherlands were more affected by that. And even Italy and other countries, which is a comparison to statement here given. The various age group population, when we compare, it was again, and the sex-wise, if we compare, the males are more affected by that. Maybe, of course, the various factors are not only the physiological factor, the possibility that they were more exposed to this COVID. The most important was this, the problem was that immune response is which is the best defense for against pathogen, bacteria, fungal, protozoan, and worms, and resistance infection. We have two types of.
Dr. Kana,
yeah.
Can you please put onto full screen?
Isn't it full screen?
It's a bit small. Yeah.
Oh, I can see my full screen here. Just a minute, let me see. Is it now? Okay.
Yeah.
I don't know. So the type of immunity which we have, of course, we all know now the innate immunity, adaptive immunity, which was really the challenges, and people were, even some of our people were not aware about that immunity, how to improve the immunity, how to change the immunity, how to keep that immunity up to that level. And then the exercise also was affected. The kind of exercise they were doing also was limited to a certain extent. And both the innate and adaptive immunity were also affected during this COVID particularly, which is what is we all again understand the cellular immunity and the humoral immunity. And it has got good relation with the exercises also, you know. Now, the enhancement of immune response, it depends, of course, on various factors, but what is most important is that which we have to consider was that improving the pre-existing physical fitness level of the particular population, decrease in body weight and fat level, appropriate diet and nutrition, the good sleep, and improving the mental health can lead to a better immunity. And maintaining the above is a challenge in the wake of physical isolation, particularly related, and the anxiety and stress which has been induced during this, and the kind of food which we were taking, which was also limited, the socio-economic and behavioral challenges of the individual, family, and society. Everyone was under some stress, some pressure, and that has affected particularly the immunity of the individuals also. So, and maintaining the regular activity, which we discussed, that is a critical component for all these factors also. That if we don't have those regular activity, again, the effect is there on the fitness part, the fat level, appropriate nutrition, sleep, everything is affected. It is really a cycle also. So how do the cycle of inactivity, we all know that can lead to chronic diseases, long work hours, long commute time. The thought of exercise is daunting, lack of time and motivation, sedentary pastime, and it really has given us the deconditioning, decrease in the strength, decrease in the balance, decrease in the fitness level, and it has increased the effect of chronic disease and symptoms. Again, whatever was COVID has created, otherwise also the other problems also, the symptoms were worsening, increased pain was there, decreased quality of life, decreased self-efficacy, increased fatigue, and mostly people were affected by them. Particularly the dramatic change in lifestyle resulting from immobilization, hospitalization, and bed time and physical inactivity caused a second wave attack on the health and well-being of the infected as well as general population. The regular practice of physical health can act in the immune response. The activity is again directly related to the immunity development also. It of course reduces the risk of developing systematic inflammatory processes and stimulating cellular immunity. What is that effect of exercise and inactivity on physical health and the risk of severe disease upon viral infection? We again understand that the inactive sedentary individuals, they have sarcopenia, goes down, the muscles, reduced muscle functions, risk factor for cardiovascular and metabolic disease, immune function is again affected, increasing the incidence of lung inflammation and bacterial pneumonia. That is again infection chances at the respiratory level are very high. It impairs our energy expenditure, increases total body fat and abdominal fat. Similarly, physical activity individual improves. If we keep doing those activities, it improves T-cell responses, decreases the incidence of urinary tract infection, inhibits lung inflammation and bacterial pneumonia, improves lung functions, induces stronger and longer fasting antibody response to the influenza, mitigates immunosensitization responses, anti-inflammatory capacity is improved, and the severity of viral infection is decreased. So maintaining that activity and the physical health was the most important challenge during this COVID-19, because we all know that physiologically we can be more adjusted risk factor for admission to intensive care unit in patient with COVID-19, BMI, body mass, and emergency department. It was really observed that patients with COVID-19 who were constantly inactive had a greater risk of hospitalization and admission to the ICU also. The death rate also was very high in them. So the most important factor was that because immunity was lacking in them, that has led them to for more infection, and also to ICU, and even the fatality was very high in this. So these are the various factors which have been studied, and it has given the conclusive that the important factor is that the fitness is the most important factor that we have to maintain to keep the immunity also at higher level. The study has been also done on earlier effect of the COVID-19 pandemic on physical activity and sedentary behavior in the children living in US. They also found that the physical activity which was reduced during this early COVID is the period from free play. structured activity, which was again reduced, was significantly, it has come down, and that may be one of the reasons for again getting prone to the infection also. Even the other studies have been done by Dr. Yamda, the effect of COVID-19 epidemic on physical activity in community dwelling older adults in Japan, which is a cross-sectional survey. There also they came to know that the physical activity time in various physical movement was decreased very significantly in the older population. Particularly in India also, the older population, the study which is not reported now, has decreased to the maximum extent, and they were actually confined to the houses only, and still they are very at risk factor, so they are not coming out for most of them are not coming out for any physical activity also. Another factor which has been affected is the emotional distress in young adults during the COVID-19 pandemic, and evidence of risk and resilience from a longitudinal cohort study was done by 11 countries on particularly mental health. India was also part of that. There also the conclusive statement which has come out of the study was that the pandemic has affected the mental health of not only in India but all across the world also, and which again has led to the decrease in the immunity. Even these people, those who are addicted, exercise addiction, the changes in the weekly hours of exercise in the 3 exercise addiction risk group, exercise primarily for health, skill or social reason as a result of the COVID-19 pandemic, the much more reduction was there, and they were at very, very high risk also. Those who were already having this addiction and regular, they were going, but still they were not able to continue, and significant reduction was observed, and the pandemic risk was increased in them also. Another group, the study has been done, the coronavirus appearing in the most are evaluated in the various groups also, age group wise, and that the changes in the exercise hours per week has gone down in most of the people. So what has happened now in the corona pandemic, even the addiction group people, those who are regular also, they are also the time of exposure to the physical activity has gone down, and the physical inactivity has been now prevailing all across this. This one again, one more study was done in India also, the physical activity among adults residing in, this is also part of that 11 countries during the COVID-19 pandemic lockdown, and one part India also participated here. And we have seen that the various countries, the activity which is reduced here was in a big way, it has gone, and the people were not able to continue their activity from very different level. Physical activity, dietary, these are all important factors which have been affected. Physical activity, dietary habit, and sleep quality before and during COVID-19 lockdown. The physical inactive people have increased. Sleep problems have increased from 63 to 75%. Eating disorder also have been affected by this. So this study also include, because of these factors, the immunity has been affected, and the chances of getting infected by COVID and the recovery rate has gone down because of this. The progress in cardiovascular disease also a tale of two pandemics. How will COVID-19 and global trend in physical inactivity and sedentary behavior affect one another? This is all correlated, that COVID-19 keys will definitely go for physical inactivity. People are going, and that will affect the cardiovascular health of the people, and it will be leading to more cardiovascular problem, which can be one of the reasons for the fatality also. So what is actually required is, we need to really take aggressive step to kill this physical inactivity. How do we do it? What are the challenges we are facing to make the population as physical activity and reduce the sedentary behavior of the population? So what all steps, what all things we can do? We all have understood that physical activity is directly, which is the most prone factors, respiratory health. Because of COVID, respiration is affected, and the blood circulation and immunity is affected now. So how do we meet these challenges? The most important factor again becomes the improvement in the physical activity level of the individuals. The type of exercises which can affect this physical activity, which are more important for improving the immunity. One is that low intensity, 40 to 50% of maximum heart rate, that slow walking, slow biking, riding, light housework, whatever, the basal, even the yoga also. The moderate, which is coming from 50% to 75% of maximum heart rate, the brisk walking, standard yoga, gardening, pulse sports, resistance training, and at least with 10 to 12 repetition per set. High intensity is 75 to 85% of maximum heart rate. So which is most important, how much we should at least maintain to keep our immunity at little higher level or moderate level. The hypothetical link which is shown here is the moderate exercise intervention and infection disease, including COVID-19 inflammation, oxidative stress, and chronic disease. Is that modern exercise intervention can lead to the chronic disease development and comorbidity, type 2 diabetes, cardiovascular disease, and the increase in the inflammation because of this infectious disease. We are having this inflammation, physical inactivity also goes, physical inactivity is also increased. So we need to really maintain at least the moderate physical exercise intervention to control the factors which will be enhancing our disease or the infection of the person. The exercise immune function and illness also, you can see what is the optimum. Optimum is the green region where we can have the intensity of moderate intensity, which will be really effective, more effective to maintain the immunity function of the person. If we are going toward the higher side and stress continuum, it is going to the overload and immunity responses, immunity also goes down with that. So if we see that even the sedentary population, they are not able to maintain their immunity, the most important becomes that we must keep this exercise workload, which is the moderate intensity for each and every person, and that will help us in maintaining our health, and the lack of infection we will be able to just counter the infection also. And moderate intensity exercise and immunity, if we see this, enhances the immune system activity by increasing the anti-pathogen activity of tissues, macrophages, leukocyte with higher number of neutrophils, NK cells, cytotoxic T cells, and immature B cells. And the regular bouts of short lasting, that is up to 45 minutes, moderate intensity aerobic exercise is beneficial for host immune defense, particularly in older adults and people with chronic disease. So this is the minimum, the moderate intensity up to, I'll say 30 to 45 minute intensity will be good enough for maintaining particularly the immune responses in the people of old population, also adult also. Again, the benefit of regular moderate intensity, it will protect against the various resistance because it has got antipathogenic activity. It proves that, and immunovigilance, pulmonary and tissue inflammatory damage is decreased, improvement in obesity, T2, and diabetic mellitus also, and various other factors which are also improvement in the various disease condition, not only in the immunity responses. The study has also been done, the association of moderate to vigorous physical activity and sedentary behavior with depressive and anxiety. The mental stress also is again one of the factors which is affected by physically inactivity, and that has been seen that among 937 participants, the female 72%, and those performing more than 30 minutes per day of moderate or vigorous activity of more than 15 minutes per day of vigorous physical activity had lower odds of prevalent depressive anxiety and co-occurring of other symptoms. Those spending more than 10 hours per day sedentary were more likely to have depressive symptoms. So we have to see that the minimum optimum level is not only required for the physical health but also for the mental health, that we must keep at least the moderate level of the activity. Another factor which has come into picture that what is important is that whether aerobic exercises also have got more important and how much time. Aerobic exercises, we again understand that increases the whole body immune system by increasing the level of function of T cell, lymphocyte, and neutrophils, macrophages, and monocyte. The aerobic exercise also increases the immunity of respiratory system by increasing level of IgGA and IgG. And it also regulates the C-reactive protein CRP and produces an early small increase in improves immunity and later decrease the lung function also. And the another factor was decreases anxiety and depression, which improves the immunity. All leads to this aerobic exercise ultimately leads to the improvement of the immunity, which is essential to prevent and decrease the progression of COVID-19. So this is one of the more important factor, that aerobic exercises even on the respiratory factors, respiratory system also, it prevents and decreases the progression of COVID-19 commonly, which is associated with pulmonary disorders and symptoms of cough and dyspnea also. So we have to see that how much is the amount which is required for the maintenance of our respiratory health. If you see this is basically a J-shaped curve. You know, high exercise workload and immunity for recreational athlete, if you say, it becomes that how much is optimum, the normal level. If it is this, if we reduce this, we are increasing 40 to 50% chances of urinary tract. If we are keeping moderate level, we are reducing the chances of any infection. Particularly here, the study has been done on URTA, urinary tract infection, and risk has decreased 40 to 50%. And if we are going to the higher level, then the risk is higher, very high. So in the sedentary population, this is very important to maintain 40 to 50%, which can reduce this infection chances here. So moderate exercise more heavy exercises can lead to the infection chances here. But in case of the very high sports person, the sports person, the athletes, again, the study has been done where the athletes, high exercise.
And I think it's very apt now because every one of us actually is affected by COVID-19 somehow. And your talk is really very useful for us. Thank you very much. And we know that inactivity is not going to help our immune system. So let's start exercising, everyone. All right. There is no question for Dr. Khanna. Is there anybody with any question for Dr. Khanna? Okay, he is blackout. That's why we couldn't. All right, he is back. I think he is back. Right, Dr. Khanna, just now you were blackout, right? So we just would like to thank you for your talk. And there is no question for you. But I would like to ask you, what do you mean by moderate exercises? Can you take just brisk walking as moderate?
Yeah, the moderate exercise is that if we have a 40 to 50% of the intensity, that is being considered as moderate for the normal population. If they can maintain that one, the risk of illness, the risk of infection is reduced in them and immunity improves in them. Of course, the high load intensity for the sports person, there it is not affecting this immunity. They can tolerate higher load also. They can go 70-80%, and the rate of risk of infection is not increasing there in them. But whereas in case of the normal population, if they increase the intensity and they go more than 70-80%, the risk of the infection is very high there. So they have to maintain within the moderate intensity, which is around 40-50%.
Okay, thank you, Professor. And I would like to know, for the very young and for the very old, for example, we have many who are already past their 80s. What do you think is the best way to, or what is the best exercise for them to build up their immunity, and for the very young?
I think what we could find out was from this study was that the aerobic exercises, the brisk walking for them is most important, because for when they do brisk walking, their heart rate that goes up to at least 40-50% of that intensity also. So that if they can maintain for 25-30 minutes, that activity will definitely maintain their immunity and even improve their immunity, as well as reduce the chances of infection also. And they can really counter sometime through their own immunity development the risk of infection, again the effect of that on the respiratory system.
Okay, there is a question for you. This is from Rebecca. Okay, she asked, how can I ask my students to perform exercise during our online class if their space is very small?
This is really a big challenge has come here. But what we could do was that one of the exercises which we recommended during this, particularly the COVID, when they were in that home quarantine, the yoga and the other kind of breathing exercises, that has really helped them in countering the mental stress, anxiety disorders, as well as maintain the physical health also. So the kind of activity which they can do at their own room, own place also, the yoga exercises or the exercise which are to limited space, we recommended at that time, and it is really prevailing and it is helping the people also in countering this, that kind of exercises we can, even the traditional certain system, the exercises which can be taken up also. In Chinese, they have different kind of exercise also. So models can be created, and plus the another important which one was the physical activity through dance. Dancing was one of the factors which has come up now, in the population. The music, with the music, they are doing some movement, and that is raising their heart rate also, and they are taking come up to moderate intensity of exercise is possible with that.
Right. Thank you. Okay, I've got the next question, which I think is very interesting. Is from Jong Sing Kyung. He would like to know, how do you assess one's own immunity without needing to go to the lab?
Excuse me?
How would you assess your own immunity without needing to go to the lab?
Oh, it's an interesting question, that is really, that if we are not getting infection very frequently, if we are not sneezing very frequently, if we are recovering from these nasal problems also, if we are not getting gasping, what one video was being shared by everyone, that you hold your mouth, this breathing for so much time, you are okay with this, that you are not able to, you will, or if you are walking sometime, you are not gasping also, those kind of things which we can just find out from. And when we are going or climbing up, we are not getting stress also. Something, these kind of things which we can find out from, or sometimes, as our earlier speaker has told us, that we need to really test through our heart rate raise also, that we can indirectly find out that what is that heart rate. Even with climbing 5-7 steps, our heart rate goes to 150-60, means something is wrong. our adaptations are not good enough. And that is directly, indirectly, it is related to some kind of immunity also. But indirectly, of course, assessing this is through our fitness test only, I can say, some kind of indirect aerobic assessment also.
Okay, that's through your reasoning, how healthy you are. That means your immunity.
Yeah, how healthy you are.
Yeah. Okay, now the next question is from Dr. Gana Bertak. Okay, he would like to ask, what is the time or the best time, I think, and duration for aerobic exercise? That means the best time to exercise and how long should we exercise?
This one is that this is a more or less different type of concept have come. You have to do exercise in your own planning way also. The best time, if you think from the Indian traditional system, they used to say that it is the morning time, which is calm, cool, and very peaceful, and when the whole environment pollutions are very less. That is the very effective time. And they also say that in traditional system, that if you can do within from 5 o'clock to 6:30 before the sunrise in a peak intensity is the best time. But nowadays, because of our whole cultural aspect, which we are in so much work environment, stressful environment, we have to accumulate some time, at least we must do activity at 20 to 34, 45 minutes. And again, the devices have been given now. We must have some number of steps we should do in a whole day life cycle, in our whole day cycle also. Sometimes they say 10,000 for some population, or it may be higher for the other population. But if we keep accumulating this, that also helps us that within 3 days, 5 days, we have done this number of steps. So we should not now that is one part. Traditionally, if you ask me, that morning time is the best time. But the another part is that we must keep doing, we must keep active also. And the whole day activity we must accumulate. And if we can accumulate at least in a week, 200 to 150 to 200 minutes, it is again good enough, as proved by some of the researchers also.
All right, thank you. We have some time, so we will answer all the questions that is put forward to you. You seem to be very popular. There's a lot of questions. Okay, the next one is from Jaguro Tula Baskara Rao. He would like to know the type of breathing exercise.
Okay, this is another one. The type of breathing exercises. They say in yogic exercises, they say that deep breathing exercises. And every time we have to focus on each and every breath also. If we can concentrate on the breath as well as do our deep breathing exercise, hold it, release it, and then again take it. And if we can move our somehow this belly also, that is a kind of a yoga exercises that really helps us in maintaining our good health also. Even the aerobic capacity has been also seen to improve. Lung function capacity also, as we have seen, that it improves with those kind of deep breathing exercises. So if we have somehow repeated breathing exercises for say 10 to 15 times, it really helps that. Plus, they say that fast breathing also is very important sometimes. You have to do through the lower abdominal, that you have to just keep doing this activity, and you will see that this also really gives much more mental as well as the other kind of improvement also. The mental health improves, the anxiety goes down, depression comes down, and the physical health, the respiratory health also improves with that. Even other organ systems are also improve with that. So yogic breathing exercises are, I think, one of the best main of this. But otherwise, you have to scientifically find out. If we talk about the high performance sports, then we have to find out what actually is leading. We have seen in swimmers, they take very shallow type of breathing. Tidal volume is very less. So how do you increase that one? Again, through some people have seen this vital capacity is very low. So taking one breath for a long time, holding it, again releasing it slowly, that may improve that one also. There are certain clinical exercise also they have with the force. You have to force certain part. So there are equipment also for having breathing. So it all depends upon what is our objective, what kind of exercise should be given to which factor is associated with that through the lungs volume, tidal volume, vital capacity, residual volume, or total lung capacity, whatever. So based on that, you have to plan your exercise and the number of repetition, intensity of breathing, and the focus part is very important. The concentration on the breathing, which we say sometimes meditation also.
Okay, all right. The next question is, for people who choose to exercise at home, what would be those effective phases of exercise you would recommend?
You mean to the places?
Phases, P-H-A-S-E-S, different phase.
Phases?
Yeah.
I'm really not clear. Phases is about what that is?
Phases of exercise.
I'm not yet clear on that. The regular exercises, the regular exercise is very important. Which phase mean time of the day, or somehow the month, or the phase wise, which phases? What is that classification of phases? Can I make it more clear from them?
Yeah, whoever, I think Sean, if you ask this question, if you would like to know more, you can contact Professor, okay? And the next question is it good to have a shower and light meal before working out, or should be the other way around?
Yeah, you see, this is again another one question, which is of course important, that generally people takes little shower before going. If you see the swimmers, we generally see them that they take shower before going to swimming, and after that also. The reason being that they have to remove that infectious thing from them, the sweating, the salt, whatever has been on this part, on the body part, is better to keep it clean before the exercise also. And after the exercise, most important, I feel that, because you have a lot of sweating during exercises, and a lot of metabolites are accumulated around the body, and that may lead to certain kind of problems for the skin also. So we have to avoid those parts, and if you keep those things with you, there may be chances more of the even sometimes fungal infection may affect also. So we must be very careful that after that we must keep our body clean and tidy also. And I don't know, sometimes it is the physical reason for recovery also is very important. That the people, they say, it is also proved also sometimes, the hot and cold bath, both are alternative. If you take, you have better recovery processes also. You get healing from your micro injuries in the muscles or different part of the body. So various, this kind of thing which we have to again find out what type of exercise he has done, and the kind of even bath is also properly designed. Sometimes for pre also activity, they say warming up, they say they want to take some kind of shower also. And after, for recovery purpose, some people want to go for the ice bath also. So it all depends upon how do you plan your whole training session. But my point is that you have to keep your whole body clean. From the scientific reason of recovery, it is better, it is always important to take sometimes the cleaning of the body after this activity.
Okay, we will take one.
Am I clear? I hope so.
Yeah. So I hope it's clear. Now, we take the last question. Can showering after gym or exercise cause heart attack?
Oh, yeah, you see, this is very, very important, but I think cardiac people can tell us, you know, anything which is really changing the circulation of the body. The circulation, you are having somehow very high circulation toward the skin. And if you change it suddenly by coming to a cold or some places, from hot to cold or cold to hot, that temperature differences sometimes make your circulation also affected. and that circulatory factors may lead to certain changes in your cardiac walls or structure. That depends upon that, how prone is he to adjust to this kind of changes. It is all about that homeostasis, maintenance of the internal equilibrium of the system. So some people, if you very cold, sudden shrinking is there, and the arteries are also shrinking. The blood circulation is affected in different part also. Even sometime at the brain level also, they may feel giddiness. So it depends that whether if you are adjusted to this kind of change in the environment, that from the body gets warm and it is around say 99 or 100 degree, and if you are making them cool to say again back to put some 10 degree temperature on this body, there will be change in the circulatory factors. So that may lead to some kind of complication. We have to always be conscious about these factors also, that sometimes environmental factor also. And taking this kind of shower also, we have to be very particular. And the more important is that medical doctors will be able to give us better advice on these changes in the particular individual.
All right. So we have the last question. So thank you very much, Professor Ghana, for your very interesting session. I hope.
Thank you very much. Thanks a lot.
Yeah.
My pleasure. Thank you.
All right. This is the moment we are waiting for. Every one of us, we have been waiting for this session. Now, our next speaker is our Honorable Dato Sri Azalina Othman Said. She is the Member of Parliament and Special Advisor of the Prime Minister of Malaysia. She is one of our keynote speaker, and I know every one of us have been waiting, so she's here, right? So we would like to hear her speak, and her topic is global aging population, staying healthy and maintaining relevance. Without wasting more time, let us welcome Dato Sri Azalina Othman Said.
Parliamentarian Dato Sri Azalina Othman Said of Pengerang, P157, has foresaw the burden of our nation in the year 2030, where the country will have more than 3.4 million, 11% population, who will be 60 years and above. We need to be prepared to meet the demands and challenges to ensure their quality of life. Pengerang itself will have more than 16,000 rakyat who will be 60 years and above come 2030. And on top of these challenges, we are faced with 42,200 residents who are hypertensive, 36,162 who are diabetic, and more than 5,000 people requiring mental health screening. Doctors in Pengerang are facing high workloads with a ratio of 1 doctor to 1,205 patients. Yang Berhormat Azalina has created the Rakan Aktif Parlimen Pengerang, better known as RAP, with 3 significant approaches. 1. To ensure the population of Pengerang are active throughout their life. The active lifestyle approach is to prescribe the elderly with the correct dosage of exercise to improve their dynamic balance to prevent falls, build strong muscular structures and bones, and maintain a healthy heart. This exercise regime is scientifically prescribed to ensure a correct dosage for the muscular system and their cardiovascular system. 2. The family members of Pengerang Rakyat are empowered with knowledge for home, i.e. wheelchair safety, wound dressing, bedridden mobilization, use of walking aids, and monitoring of blood pressure and blood sugar. And 3. A healthy mind. To ensure the proper mobilization of the entire process, we are urgently in need of healthcare careers ranging from 6,000 exercise therapists in the next 6 years.
Good afternoon to the organizing chairman, Datuk Seri Dr. Jessie Lai, the members of the scientific community, His Excellency Kung Pao, the Deputy Secretary General of ASEAN, Dr. Ferdinand M. Fernando, the Assistant Director and Head of Health Division of the ASEAN Secretariat, Dr. Noariana Hassan, Country Coordinator for ASEAN Health Cluster 1, Puan Suraya, Director of the Health Education Division, Ministry of Health Malaysia, fellow medical practitioners, researchers, coaches and students, and good morning to fellow colleagues from Europe and other parts of the world. Chairman of the session, ladies and gentlemen, as the biological level aging results from the impact of the accumulation of a wide variety of molecular and cellular damage over time, this leads to a gradual decreasing physical and mental capacity, a growing risk of disease and ultimately death. These changes are neither linear nor consistent. Commonly, the health conditions that arise due aging are non-communicable disease, neuromuscular skeletal pain, and deterioration which leads to fall. United Nations General Assembly declared 2021-2030 as the decade of healthy aging, and the World Health Organization will be leading this implementation. The world has always been having more young children than elder ones, but we are witnessing a major shift that has never occurred in the history of mankind, where young children are about to be outnumbered by the aged population. Nations go through aging population where there is a decline in fertility rate and increased life expectancy. The number of people aged 65 or older is projected to grow from an estimated 524 million in 2010 to nearly 1.5 billion in 2050, with most of the increase in developing countries. Thus, all aging nations face major challenges to ensure that their health and social systems are ready to make the most of this demographic shift. This undoubtedly requires a sharing of responsibility between the government, private sector, non-governmental agencies and the community, as aged population has its own unique problems and will generate new challenges and demands on the health and social services. Japan has the highest proportion of older adults in the world. The country enjoys the highest life expectancy in the world with relatively low healthcare costs. Despite this, Japan precedes others in experiencing a super aging society due to stimulus population aging in decline. This must be taken as a lesson by other countries in encountering the aging phenomenon. For all aging nations, certain levels of proactive steps should be initiated to tackle the situation by creating more platforms for elderly. Number 1, community structure. Number 2, housing structure. Number 3, communication and transport. Number 4, outdoor. And number 5, health. Malaysia is one of the countries that is facing aging population. The number of Malaysians aged 60 years and above is estimated to be 7% as of now, and is projected to increase to 15% by the year of 2030. Our Malaysian government is looking into this sector of population seriously since 2016. In my care for aging population in my constituency, I have implemented a 3-tiered approach. Number 1, to build an outdoor environment to assist elderly to remain active throughout and achieve a good quality of life. Number 2, to ensure the elderly are exercising correctly with right dosages. And number 3, to maximize the involvement of elderly within the community. Called as the Active Aging Centre of Pengerang, it acts as an exercise and educational centre for elderly and their family members. To ensure exercise are prescribed with a proper dosage and executed in the correct way, to ensure family members can interact with their elderly in terms of vital signs. These family members will be educated on the procedures to monitor their vital signs are stable. Their resting heart rate, blood pressure, sugar level, oxygen level, body weight. Safety use of wheelchairs and walking aids, techniques of transferring elderly from bed to chair and from chair to bed. All these programs are conducted by trained and qualified exercise therapists with a complete technological empowered and automated exercise system, which is locally designed and in collaboration with Japan, Korea, Taiwan and Australia. The centre is located in Pengerang, Johor, the south of Malaysia. Pengerang has more than 100,000 population and mostly are heading towards their old age. Thus, this centre will act as a medium to to push the population towards healthy aging. All elderly are to go through a full physical fitness assessment and will be guided throughout their exercise program. Aging will be a wonderful experience individually and also globally if more actions are taken to overcome the loss that might come together. We must understand that the capacity of an 80-year-old might be the same as the 30-year-old. Thus, job opportunities that is relevant for aging population can be provided. More care centers like the Active Aging Center can be established, and also other long-term care policy can be given to the aging population. This is all to allow aging population to continue to contribute to the nation as well as being taken care of. Thank you and good luck to your conferences. Thank you so much.
Penuaan adalah proses semula jadi. Akan tetapi, penuaan haruslah dihadapi secara sihat dan tidak menjadi beban kepada orang lain. Menjadi seorang warga emas yang sihat tidak semestinya bebas daripada sebarang penyakit. Warga emas yang sihat sepatutnya dilihat sebagai seorang yang mempunyai kualiti hidup yang baik. Seseorang haruslah mampu berdikari dan mampu untuk bergerak dengan sendiri. Untuk mencapai kualiti hidup seperti berikut, kita seharusnya bersenam dengan kerap di samping menjaga pemakanan. Saya adalah seorang yang kerap bersenam dan nasihat saya kepada yang sedang menuju ke arah status warga emas adalah untuk memastikan senaman itu dijadikan sebahagian daripada rutin seharian untuk mengelakkan pengecutan otot dan mengekalkan stamina.
Tun, berapa kali Tun bersenam dalam satu minggu?
Saya kalau boleh itu tiap-tiap hari lah. Tapi tak ada masa, kadang-kadang 2 hari sekali, 3 hari sekali.
Tun, bagaimana Tun cari masa untuk senam apabila Tun tidak berada di rumah ataupun masa Tun berjalan?
Masa kita berjalan ke tempat lain, sukar untuk kita teruskan rutin kita. Tetapi ada cara-cara lain. Umpamanya kalau kita boleh berjalan, kita berjalan sedikit. Dalam rumah pun boleh. Dalam rumah pun saya biasa berjalan sehingga 6 round di atas beranda. Itu mencukupi bagi saya.
Adakah Tun melakukan latihan berbadan?
Weight ada. Saya guna dumbbell. Dumbbell angkat sikit. Tapi weight yang berat tidaklah.
You are on mute, please.
Okay, thank you, Datuk Sri Azalina, for the talk on global aging population, staying healthy and maintaining relevance. And the video you just watched, it is in Bahasa Malaysia, that's our national language. So for those foreigners, if you do not know, he is our ex-Prime Minister, and he is, I think, 94 or 95, I can't remember, years old. And he is still very, very healthy. And he has given some advices on how to do exercises. Like, for example, even in the house during COVID, he walks around the house and he takes a dumbbell, not too heavy, you see. So if 90 over years old is still exercising, I think we should be exercising. All right. Is there any questions that you would like to ask? All right, since there is no question, All right, since there's no question, then we will move to those of you who would like to listen to Dr. Yen. He is in the other room. That is, if you please look at the chat, you will see the link to the chat to his room. He will be chairing the session and he will also be talking in that room, okay? So if you would like to listen to Dr. Yen, please move to the other room. Thank you very much. We see you again.
Hi, ladies and gentlemen. I believe we have been in this fixed position seated for more than half an hour. And according to ergonomics, it's one of the risk factors to be fixed in certain position for too long. It's no good for our body, no good for our posture and our muscles. So I would like to introduce to you the X break. It's a set of simple exercises and also stretching that would help us break the cycle of being static. And it's introduced by Malaysia Ministry of Health. Come, let's join me.
You know. Masivo. We run the world. Vamos con el ritmo, cintura, rodilla, el piso va y pasa el limbo. Vamos con el ritmo, cintura, rodilla, el piso va y pasa el limbo. Y esto está como pa rumbear, pa pasarla caliente con toda mi gente. Nos favorece el sol, tu bronceado y el calor, no puede estar mejor. Y esto está como pa rumbear, pa bailarlo caliente, de pal y de frente. Nos favorece el sol, tu bronceado y el calor, no puede estar mejor. Súbela, bájala y ponle bajo, pásala, suelta la cadera y mueve todo lo que tienes ahí. Sigue, sigue, este party no tiene fin. Activado, brinca la casa candela, canta la suela, funde esa tela, así que me paso que suena la rumba buena, que hay muchas nenas, mira la escena que para arriba no la dejes caer. Seguimos hasta el amanecer. Vamos con el ritmo, cintura, rodilla, al piso va y pasa el limbo. Vamos con el ritmo, cintura, rodilla, al piso va y pasa el limbo. Y esto está como pa rumbear, pa pasarla caliente con toda mi gente. Nos favorece el sol, tu bronceado y el calor, no puede estar mejor. Y esto está como pa rumbear, pa bailarlo caliente, de pal y de frente. Nos favorece el sol, tu bronceado y el calor, no puede estar mejor. Bailando así es que me gusta, como la cintura ritmo se ajusta, es que me tiene loco tanta soltura, ese movimiento es una dulzura. No importa las banderas, se formó y sal pa' afuera, aquí cabe todo el que quiera. No lo pare ahora, dime para arriba no la dejes caer. Seguimos hasta el amanecer. Trinidad llegando de Aruba, gozando la temperatura, yo te vi bailando el limbo. Neverita puesta en la esquina, tu DJ par de bocinas, y todos llegarán por el ritmo. Porque esto está como pa rumbear, pa pasarla caliente con toda mi gente. Nos favorece el sol, tu bronceado y el calor, no puede estar mejor. Y esto está como pa rumbear, pa bailarlo caliente, de pal y de frente. Nos favorece el sol, tu bronceado y el calor,
Thank you, Dr. Siu. Dr. Siu, Professor Siu, I should call him. Thank you very much for your X-break sessions. Really interesting to watch you exercise. Now, just an announcement. Symposium on Exercise and Heart will be in breakout room 1. And the other one is Symposium on Exercise and Cancer will be in breakout room 2. Now, the link is already on the chat. Please look up the link and choose whichever room you want to go. Thank you very much for today's listening in. And we hope to see you tomorrow. Welcome tomorrow, everybody.
Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms. Here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Keep moving. Keep moving. Keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is yours now, so just keep moving. Yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the
Hello, good afternoon. Hi. I hope everyone is enjoying your papers so far until now. We have today we are going to continue with the exercise and the heart. Unfortunately, Dr. Ian Lahad, he has been extremely busy. He will be presenting this paper in the Symposium, I think I have been told. But it's okay. Anyway, the show goes on. Thank you, Dr. Ian. I know you're very busy and you're taking all your time. It's time for us to have Dr. Patrick Dunn from the United States of the American Heart Association. So thank you very much for accepting our invitation to come over here and present your on health literacy and motivation to exercise. Dr. Dunn is the program director for the Center of Health Technology and Innovation in the AHA, the American Heart Association, right? And he is also the founder and president of the Your Heart Score, also a contributing faculty, School of Health Sciences and Instructional Support Specialist, Walden University Academic Skills Center. All right, so Dr. Dunn, the hall is yours. Thank you.
Thank you. Let me get my. All right, so thank you. It is an honor to present at your meeting. I'm presenting today from Austin, Texas, where it's a little bit after 3 a.m. local time. The good news is I'm free of distractions. My schedule's clear and hopefully my phone will not ring. So briefly, again, my name is Patrick Dunn. I've worked as a clinical exercise physiologist for the past 35 years, primarily in the area of cardiac rehabilitation and cardiovascular disease management. And as was stated, I'm the program director of the American Heart Association Center for Health Technology and Innovation. And I'm also contributing faculty at Walden University College of Health Professions. I'm also a trained software engineer. My interest and passion is in health literacy, specifically digital health literacy, and how it relates to better health outcomes. Exercise and physical activity are key components of managing heart health and preventing cardiovascular disease. Exercise training has been shown to increase cardiovascular fitness and is associated with better control of blood pressure, cholesterol, glucose, and weight. While the benefits are many and the risks are few, there is a strong behavioral component to exercise and physical activity, making it easy for some and difficult for others. We know that if exercise was a drug, it would be a blockbuster. The problem is compliance with exercise and physical activity recommendations is still very low. And as a therapeutic, we also know that rates of participation in cardiac rehab is low. So if exercise is so great, why is compliance so?
For 4 to 6 hours receiving an infusion of chemo, and then they take a break for a few weeks, allow their body to recover from that, and then come back and receive another bout. So what's really interesting, if you track resting heart rate from the time of an initial infusion, Amy did some really interesting work here where the mean heart rate at the start of an infusion or before an infusion, hanging in around 65 to 67 beats per minute, should I say. And then gradually over the days of chemotherapy receipt, after an administration, it bumps up to about 75 beats per minute. Now, that might seem fairly inconsequential, but if you're doing a cardiovascular program and you're basing that cardiovascular program on resting heart rate that you took at the start of chemotherapy, you're going to be giving individuals a different dose in this kind of 7 to 8 day period than you would at the start of a baseline. So it's really important to understand how these acute changes in heart rate could impact your exercise prescription and their ability to receive that exercise prescription. So it's really interesting that we have this kind of curvilinear response where after the receipt in terms of a few days, got this peak in heart rate rest and it starts to come back down towards baseline. But if you then look at how those cycles of chemotherapy kind of put back to back, so oftentimes, again, as I said, you might have chemotherapy once every 3 or 4 weeks and you stagger them across cycles. So if you've got 6 cycles in a 6-month period, well, then that starts to look a little bit different too, where instead of coming back down to normal, coming back down to baseline, you track those heart rate changes across the course of a chemotherapy treatment. Then you're starting to see really interesting changes where, again, you're seeing about a 13 to 14 point bump in beats per minute in resting heart rate. But it also has some really interesting
ability to know, understand, and manipulate numbers, such as the minutes of exercise and a target heart rate. Navigation is a building block stage that incorporates their knowledge and numeracy and applies this information to critical health literacy domains, including communication and decision-making, helping the person know what to do with the information. Without health system navigational skills, the patient will not know what questions to ask and which is necessary for good decision-making skills. In the context of exercise, navigation includes where to exercise and who to get direction from. The final 2 domains of health literacy are classified as critical health literacy skills and include communication and decision-making. Much like navigation, communication itself is a skill that sets up the decision process. Examples of communication is reporting of symptoms and getting advice on exercise programs. The final and ultimate level of health literacy is decision-making. Decision-making can be unilateral, such as beginning an exercise program, and shared decision-making, such as starting a cardiac rehab program. Strategies for building health literacy skills for exercise is a 3-step process. The first step is addressing the emotional state of the person and establishing a support system. The second step is developing a behavioral approach designed to engage and motivate the person. The third step is to develop an instructional strategy designed to build health literacy skills. Before engaging in a behavioral and educational strategy, the emotional state of the individual needs to be addressed, and a support system needs to be identified. If the person is depressed, anxious, or experiencing a lot of stress, it'll be very hard to begin an exercise program or even increase their current level of physical activity. The exercise program itself can be helpful in managing stress and emotions. The support system can include an exercise class, a personal trainer, an exercise buddy, or a cardiac rehab program. The support system can help to further reduce anxiety, can be a way to share personal experiences, and can be an instructional platform itself using informal methods. Building a support system is like the scaffolding around a building. It provides the structure. It is critical in the early stages when the building is pretty unstable. It does not really ever go away like a building scaffold, but it can move into the building structure itself. So why does a support system matter? It helps reduce anxiety and can be a way to share experiences and learn from others' experiences. And it can be an instructional platform itself. Since people may not have a personal experience, they can learn from other people's experiences. Once the support system is in place, a behavioral approach can be initiated. This approach should be designed to be engaging and confirm the commitment to achieving the goals of the program and consider the person's readiness for change, self-efficacy, and level of knowledge or literacy about the topic. In the case of exercise, the person's prior experience and success with exercise will be a clue. If they've had a bad experience with exercise or have not been successful in earlier attempts, this should be considered in addressing the emotional state and establishing the support system. Best practices in health coaching to modify lifestyle behaviors include goal setting, monitoring, frequent contact, feedback, reinforcement, modeling, problem solving, and relapse prevention. Goal setting should be SMART, which is specific, measurable, achievable, realistic, and time-bound. For example, starting a walking program that progresses to 150 minutes of moderate activity per week over a 12-week period. Monitoring can include the use of a physical activity tracker to monitor progress. Motivational interviewing is a behavioral approach that has been used effectively to modify behaviors, including increasing physical activity and participating in cardiac rehab. Guiding principles of using motivational interviewing for health behaviors include resisting the reflex to right the person, understanding and exploring the person's own motivation, listening with empathy, helping the person develop the discrepancy between where they are and where they want to be, and supporting self-efficacy by empowering the person, by encouraging hope and optimism, by avoiding arguments and rolling with the resistance. Key skills include reflective listening and identifying self-motivational statements made by the person. A key element is to avoid arguments and roll with resistance. A strategy to avoid arguments is to find a place to start and something that is doable. Find an exercise modality that they can be successful with. Walking is usually a good place to start for most. And a good strategy for dealing with resistance is finding something positive. For exercise, that could be finding something you enjoy about exercising. For me, it is how I feel immediately after my workouts. That is my reward. And so the single most important skill in this whole process is listening. Listen with empathy by acknowledging the struggle, sharing a common experience, and being positive at all costs. For example, I know this is really hard for you, and exercising is a new experience. The good news with exercise is there are many ways to show improvements, increasing your time, increasing the duration, and increasing intensity. The key is getting the person on the right side of the argument. It is human nature to take the opposite side of the argument, and boy, do we see that in today's world. Try this out on a family member. Tell them they need to do more exercise and see what kind of reaction you get. You have won the participant when they are the one arguing for change. So what makes them do that? The key is finding the discrepancy between their present situation and where they want to be. For example, so exercise makes you feel better, but you have a hard time finding the time. Look for self-motivational statements, such as recognition of the problem, concern, or stating intention or optimism. And you do that by getting the person to explore, look at pros and cons, the extremes, and looking ahead. Once the support system is established and the person's level of engagement and motivation has been identified, an instructional strategy can be implemented. Going straight to an instructional strategy without addressing the support system or the behavioral elements is less likely to succeed. The instructional strategy should include a progression in knowledge and skills, starting with foundational skills such as walking and progressing towards a goal by increasing duration, frequency, intensity, or moving to other activities. The instructional strategy should account for the preferred learning method of the individual, incorporating both formal and informal methods. Finally, the instructional strategy should identify gaps in knowledge and skills, including how to use exercise equipment or digital tools and how to perform the exercises. So let me show you an example. So in the science of teaching, we teach children how to read, and we progress from letters to words to sentences, and eventually you're reading and maybe even writing books. In music, you start with sounds, progress to notes, then songs, and then eventually you might be on stage performing. In athletics, we progress from standing to walking to running, and eventually some of us are Olympic athletes or professional athletes. Now let's take a look at how we approach healthcare. The approach many times is to simplify the message, and there's nothing wrong with that. We go down the chain, so from lipoproteins to cholesterol to fats. But the key is to move back up the chain. So once you find that foundational space, then move back up also to achieve mastery. So we use educational theory as much as behavioral theory. And there are models we use, again, to teach children to read that apply, including Bloom's taxonomy, so ranging from remembering to understanding to applying, analyzing, evaluating, and creating. We also use Gardner's theory of multiple intelligences. People have different ways that they learn. Not everybody is a visual learner, even though that's what most people self-identify, but there are other ways. There are, kinesthetic and linguistic ways to learn as well. And then finally, Vygotsky's zone of proximal development, which is really finding that range, that zone of learning for the individual, starting at the foundation and building to what the learner can do by themselves and also with guidance. So a key part of an instructional plan is to make it as personalized as possible. There is no one-size-fits-all approach to exercise. In addition to the person's readiness for change, self-efficacy, and level of knowledge, there are other key factors, including whether the person is proactive or reactive. Are they self-directed or others-directed? Is their goal orientation to themselves or to a group, such as family members? And are they independent, so they like to do things on their own, or interdependent, which means they're more social? And finally, do they prefer direction or choices? Based on these characteristics, and including their social, medical, lifestyle, learning, and digital status, literally a signature can be created, resulting in a highly personalized plan. Digital tools are increasingly playing a role in improving exercise and activity literacy. These tools can include wearables that track the level of activity, heart rate, respiration, sleep, and temperature, connected devices that monitor blood pressure, glucose, and other biometrics, and apps that can provide information, connection with healthcare professionals and other patients, and can share self-reported data, such as symptoms. From a health literacy perspective and motivational perspective, it's not only the hardware and the wearables, but it's also the software. It's the messaging that can make a huge difference. Data analytics is also very important, using things like artificial intelligence and machine learning and big data that can result in better health outcomes, using techniques such as deep learning and a term I use, which is human-enabled AI. So the key points with health literacy: speak their language. Don't talk over their head, using a lot of jargon, but also don't talk down to people. And be sure that their understanding is actionable. So what does this look like? Follow the science and be evidence-based. Use human-enabled AI. This is not man versus machine, and it can be high-tech or low-tech, but look for patterns of success. Identify the key words and don't be afraid to use them. Use SMART goals and help the person develop a care plan. Get the person on the right side of the argument using reflective listening. Look for self-motivational statements such as, "I think I can," or "I know this is important." And use personalized messaging to consider the context of the social, medical, lifestyle, and learning signature of the individual. So thank you, and happy to answer any questions. Oops, Domenico, I think you might be on mute.
Okay, central coordination. Thank you, Dr. Dan. Thank you, Patrick. It's a long time friendship and cooperation. Once again, I greatly appreciate you exactly on this opposite side of Kuala Lumpur. So this is a very special time. And I think I appreciate very much the tone and the items that you gave to us, which are an intertwining of mind, technology, and people. And this is a lesson I would like to share also with my students as well. There is a point that I like for you to explain a little bit while we wait for questions. The human-driven AI, because AI per se is somewhat scary and I would say somehow powerful but dangerous. What's your position?
Yeah, so that's why I use the term human-enabled. So not just using a machine, just using a computer to make a decision, really leveraging the information so that the professionals can really make, best use of their time and best use of their knowledge and expertise. So it's a combination of the human expertise with the data processing that a computer and a technology system can use.
Okay, thank you. In the meantime, the same question came from one of the friends connected, named Muzaffar bin Shamsul Muzardi. So I think this will good for us. While waiting for another question, we have just one quick comment that I would like to ask you, since there is nothing else. How would you grade the communication difficulties in trying to transmit the nice scale from starting to mastery? And it goes exactly with the question of Rosny Chalet, how we can penetrate the mindset of people who only want to do sports if properly equipped. So the mind is the key. Any suggestion for
Mine is the key, and it's not a one size fits all. There are different types of people. So really trying to understand the person, where they are. They might not have ever exercised at all in their past. So you have to start very basic. Start with something that they can do and find something that they can be successful with. So, and that might just be walking an extra minute, but they can see their progress. And as they start building confidence and self-efficacy, then many times they can continue to progress to mastery, however that's defined for the individual. Mastery might just simply be, I can play in the park with my grandchildren. It doesn't have to be winning a gold medal in the Olympics.
Absolutely. Thank you very much. I think time is up. We need to lead the floor to the other speaker. Thank you again, and hope to see you somewhere on the planet on a live conference. Thank you, Patrick. Okay, now we move to the next presentation. If we can have the introduction slides, so I can introduce the next speaker, which is, according to the original schedule, Professor Dominic Hansen, in his position of being chair of a working group of the European Association of Preventive Cardiology, and he will share with us the why and how of exercise and the heart. This is not just the title of a presentation, it's the position statement of the European Association of Preventive Medicine. I understand we have his recording because the time of the day and this particular day had him committed somewhere else before this. So we follow the recording, and I will be happy to get the question and answer. He will try to join us any time. Please, we are ready for the recording. There it is. We can go to the recording. Thank you.
Dear colleagues, welcome. My name is Dominic Hansen. I'm a full professor of exercise physiology and rehabilitation at the Faculty for Rehabilitation Sciences at Hasselt University, and also principal investigator at the Department of Cardiology in Yes Hospital, Hasselt. It is a great pleasure to allow me to talk about the why and how of exercise in the heart, a position statement from the European Association of Preventive Cardiology. I have no conflicts of interest to be declared. Now, let's first have a very brief look at the current effectiveness of cardiovascular rehabilitation. In patients with coronary artery disease, we know that exercise-based multidisciplinary rehabilitation does lead to significant reductions in mortality after acute coronary syndrome coronary artery bypass graft or in mixed populations. And these risk reductions go from 40 up to 60%. In patients with heart failure, slightly different results have been obtained during the last few decades. And there we know that there's a trend for a reduction in total mortality in the long term, but a significant reduction in the number of hospitalizations during follow-up, at least up to 1 year of follow-up. So that basically means that cardiovascular rehabilitation is really important, both to patients with coronary artery disease, but also to patients with chronic heart failure. Now, how should this exercise be prescribed? That is actually what this talk is about. Let's have a look at a position statement that came out in Europe 1 year ago, detailing the FIT principles in cardiovascular rehabilitation. And according to this guideline or this position statement, patients with cardiovascular disease in general should exercise for at least 3 days per week, and we should try to build up to 6 to 7 days per week. On top of that, 2 times per week, these patients should also be exposed to resistance strength training. In general, very often moderate intense endurance exercises are being promoted, and this also applies to strength training. We should at least provide 20 to 30 minutes of exercise per bout and try to increase the duration of this exercise bout up to 45 or 60 minutes. And eventually we should try to achieve a total energy expenditure that varies between 1,000 to 2,000 kilocalories per week. And of course, this is all based also on the physical fitness of the patient. So those patients who struggle with achieving those goals from the very start should be offered a time to increase the volume and intensity of those exercises. Now, the most important thing that I would like to talk about is how to set the intensity, because when you look at the intensity recommendations, you can still see that there is a quite range of those intensities, very different parameters you can use. So the question is exactly how can we or how should we prescribe exercise intensities to those patients with cardiovascular disease? More than 10 years ago, there was a position statement on exercise intensity prescription in cardiovascular disease, but in the last decade, many new studies have been published that did provide us great insights and new insights in how to determine the exercise intensity. And I would like to summarize the outcome from this position paper in the upcoming 10 minutes for you. The 3 questions I will raise throughout this lecture is, does the exercise intensity affect the clinical benefits of cardiac rehabilitation, but also the medical safety? And if we then know that indeed different exercise intensities will lead to different outcomes, then the question is logically how to determine the exercise intensity. And I will first start with how to do that in endurance training in cardiovascular disease, followed by how to do that in strength training. So let's start with endurance training. And the first question you might ask yourself is whether the continuous exercise intensity would affect the outcome. And the most important parameter or most sensitive parameter to assess the impact of exercise intensity is obviously the VO2 peak or the exercise capacity. Well, it turns out that in patients with chronic heart failure, there is an association between exercise intensities and change in VO2 peak, but this association is of a very, very small magnitude. And also, when you look at the total energy expenditure, that seems to be the most important training modality to improve VO2 peak. So if we want to maximize the effect of exercise training on the VO2 peak, it's the volume that is key in patients with heart failure, and to a lesser extent to the continuous exercise intensity. If you look at patients with coronary artery disease, well, strikingly, nearly the same results come out. So in univariate analysis, there is a relation between the applied continuous exercise intensity and the magnitude and change of VO2 peak. But if you then correct for the total energy expenditure, that univariate relation seems to disappear. So also in coronary artery disease, it's the volume that matters the most. Now, obviously, in order to achieve a significant volume of exercise, you need to determine or at least select a proper exercise intensity that maximizes the likelihood to achieve a great exercise volume. We then may ask ourselves whether maybe we should go for high-intense interval training, because during high-intense interval training we can achieve way higher or greater exercise intensities as opposed to continuous moderate intense exercise training. Now, this training modality has been examined many times in the past 10 to 15 years. And when looking at this systematic review meta-analysis in heart failure, it turns out at the upper part that if you compare HIT versus MIT, that high intense interval training does lead to greater improvements in VO2 peak. But please be aware that if you want to assess the impact of exercise intensity independently on VO2 peak, you need to make sure that the total exercise volume is the same between treatment arms or interventions. When you do that, when you only look at isocaloric studies, in which the total volume of exercise was comparable between two different treatment arms, there the statistical significance seems to be lost. When we look at patients with coronary artery disease, exactly the same comes out. So generally, HIT seems to be more effective to improve VO2 peak as MIT, but if you then correct for volume of exercise, the impact seems to disappear. So basically, this means that HIT is not automatically more effective than moderate intense continuous training. It's a more time efficient training mode. So you can reduce the time you invest in exercise sessions by offering high intense interval training to patients with cardiovascular disease. The question then also is, if you apply higher intensities, is that actually safe? Well, this has been summarized in a recent systematic review in which they found that moderate intense continuous training or high intense interval training were equally safe, meaning that there was no difference in the rate of adverse events between trials. But we should be careful with this conclusion, because we know that in most studies in which high-intense interval training was examined, very often low-risk and clinically stable patients were recruited. The exercise interventions were of relatively short duration. Actually, those studies were not powered to measure safety outcomes, and the exercise training was supervised. So this basically means by doing that, obviously, you do have a lower risk of adverse events during exercise training. So that still means that applying HIT in unsupervised settings with clinically less stable patients and for a longer duration, that remains to be studied actually. But we do also know that the absolute risk of cardiovascular rehabilitation is very low. So now we know that the intensity does play a part to a certain extent. It's an important modality to achieve a sufficient volume of exercise that gives way to greater improvements in VO2 peak. And we also know that if you select higher intensities but for shorter duration, you can get similar improvements in the VO2 peak when compared to moderate intense continuous training. The question then rises is, how should we determine the exercise intensity? This is a table that I have downloaded from the European Sports Cardiology Guidelines of 2020. And what you can see is that there are different parameters in the upper bar, like VO2 max, maximal heart rate, etc. And on the vertical axis, you can see that there are different exercise intensity domains. So that basically means for clinicians, if, for example, you would offer moderate intense exercise to the patient, you should follow the orange bar to the right, and then you can see to what percentage that would correspond for each different parameter. And so these types of graphs are being used and have been used many times in rehab centers and hospitals. But there is a problem with those exercise intensity domains. A couple of years ago, we have shown that if you would determine the first and the second ventilatory threshold in patients with cardiovascular disease, and you would then extrapolate that to the patient's individual exercise intensity domains, very strange results came out of that. For example, for VO2 peak, the first ventilatory threshold actually corresponded to all the different exercise intensity domains, and you can also see that there is a large spread between those domains. So that basically means that, for example, the first ventilatory threshold at VO2 peak does not correspond to low or moderate intensity for all patients. It's very heterogeneous. The same was found for the second ventilatory threshold, where you can see that this threshold corresponded to high but also very hard exercise in patients with cardiovascular disease. And if you then take, for example, a different method to set the exercise intensity in the training session, for example, percentage of peak workload capacity, then you can see that all of a sudden moderate intense exercise and high intense exercise have been elicited. So that basically means that there is a discrepancy between what we measure if we determine the first and the second ventilatory threshold, which is the actual physiological individual response of the patient, versus the proposed exercise intensity domains. And we were not the only one. Subsequent papers verified these findings, including in healthy individuals. This is an interesting study showing that what happens when you use standardized in Table 1 exercise prescription, which we very often would do, that's based on the exercise intensity domains, versus individual exercise prescription, basically meaning based on the VT1 and VT2. And the outcome is very different. In the upper figure, you can see in the gray bars that a significant number of people do not respond to exercise when you offer standardized exercise intensities, while in figure B, you can see that all patients responded when individual exercise intensities were provided, meaning that selecting the VT1 and VT2 is a much wiser choice as opposed to using exercise intensity domains. And how do you do that? Well, if you want to determine VT1, VT2, you can use the V-slope method shown here in this blue arrow, and or the action uptake equivalent methods. And to determine VT2, you use the VE-VCO2 slope method in the red arrow, and or you can also use the CO2 equivalent methods, and that's the standard way of determining VT1 and VT2. And if you then have a VT1, VT2, that is a number you can extrapolate to the heart rate, the workload, or the time of exercise. In clinical practice, very often also the bulk ratings of perceived exertion can be used, shown on the left side, but also, for example, the talk or speech test, shown on the right side. But what we have learned from studies is that the Borg ratings of perceived exertion, they do have a correlation with physiological exercise intensities, but this is not as high as very often thought. And if you use the talk test, there is indeed a good intra-class correlation, but on the other hand, when comparing VT1 and VT2 with the talk test intensities, the level of agreement demonstrates right ranges. So that's why we have decided and now recommend that the bulk ratings of perceived exertion, the talk test, should be used as an adjunct to objective methods for determining the exercise intensity. But on the other hand, they should be used once an objective method has been applied in order to provide a shared decision-making process, meaning having a dialogue with the patient and how do they perceive the exercises during training. So therefore, the following position paper statements were formulated. First of all, the assessment of VT1 and VT2 during CPAT, that's the golden standard to set the exercise intensity in patients with cardiovascular disease. This is the golden standard. That basically means that if you do not have the availability of cardiopulmonary exercise testing, that's when you can go to the exercise intensity domains and go for percentages of VO2 peak, heart rate peak, etc., etc. And once you have this objective assessment of the exercise intensity, then you use the Borg rating of perceived exertion and the talk test as an adjunct on top of these objective methods. What about strength training? Well, this is the general rule of thumb to set the intensities of strength training. So you can see it goes from low up to high intensities with 12 to 15 repetitions per set of strength training. Strength training is, however, very, very important. Show here in this slide. If you add in strength training on top of endurance training, that's the CT, then the VO2 peak changes drastically more as opposed to aerobic training only. So strength training should be added on top of endurance training. The question then comes whether we should go for high or low intense strength training. Well, this is a meta-analysis in elderly individuals showing that actually the higher intensities of strength training should be used because this will lead to greater improvements in muscle strength. This is another slide showing that also the volume does play a role. So if you apply more sets, for example, 3 sets, in the gray bars versus 1 set in the black bars, you can also see here that lean tissue mass, but also muscle strength goes up significantly more. So also the volume is very important of strength training. However, there is very often this fear to apply high intense strength training because we are very often assume that greater increments in systolic blood pressure and cardiac output is elicited, but this is actually not true. In this systematic review, we show now that indeed high intense strength training is more effective to improve muscle strength, but studies have shown that the blood pressure increases as well as cardiac output increases are not higher as opposed to low intense strength training. Actually, low intense strength training very often leads to greater increases in blood pressure and cardiac output. But it's important to avoid the Valsalva maneuver. That's really important when you apply higher intensities of strength training. But if you do that, then higher intensity of strength training seem to be safe. So how should you then set the intensity of strength training? Well, we very often estimate the 1 repetition maximum with these equations. So what you do is you allow the patient to do a number of weight lifting on a device, and if the patient is not able to achieve them more than 10 repetitions on that device, then you can actually calculate the 1 repetition maximum, and that's the weight that you should use in strength training. On top of these objective methods to determine the exercise intensity, you can also use the omni-RES, which is a ratings of perceived exertion scale specifically for strength training, allowing you to do shared decision making. So these are the position statements then for determining the exercise intensity for strength training. What we always will advise you to do is to calculate the 1 repetition maximum by using submaximal repetition maximum tests. And if you know that, then you should additionally apply the omni-RES for shared decision making and to get a perceived exertion of exercise. So this is the final slide showing you how that exercise intensities should be determined in cardiovascular rehabilitation. Thank you very much. Thank you very much for your kind attention.
Thank you. We are glad for Professor Hansen to have sent this presentation, which is quite a lesson and a syllabus for everyone. The time is running, and we need to start with the next presentation to be in time also for the abstract presentation. And Professor Hansen said to me that he is available to collect a future Q&A through the conference secretariat and then forward them either to me or to him, and he or me will be very happy to reply. I see no standing question in the chat box for questions, so I'm glad to introduce you all to the next speaker. His name is Dr. Francesco Marante. He's a cardiologist working in the San Raffaele Hospital in Milan. He's also a member of the European Society of Cardiology and the European Association of Preventive Medicine, and just recently to the newly formed and very promising Italian Association for Clinical Preventive Cardiology and Rehabilitation. We can go and now thank and listen to the presentation of Dr. Maranta, which is important for understanding the limit, if any, for complex patients to do exercise. Let's go and listen.
Good afternoon to everyone. Is it a great pleasure being here with you to discuss this important issue that is the exercise in the frail patient. We all know that cardiovascular disease is the most prevalent non-communicable disease and is the leading cause of death globally. The burden of cardiovascular disease is growing. By 2030, 23 million people per year are predicted to die from cardiovascular disease, and more people are expected to be diagnosed with cardiovascular disease. Cardiovascular disease is also the leading cause of disability because of the large number of non-fatal events with important costs for healthcare systems. Certainly, we are observing important epidemiological changes in cardiovascular disease population with a movement towards older people who are more likely to be frail and to have greater comorbidities. Certainly, there is a decline in cardiovascular mortality, but hospital admissions for cardiovascular disease have continued to rise, and this is particularly true for older patients. Frailty, we said frail patient. What is frailty? Frailty is a geriatric syndrome, a complex clinical syndrome characterized by a vulnerability status associated with declining function of multiple physiological systems with a loss of physiological reserves. Certainly there are people with an accelerated aging that become frail earlier if compared with people with normal aging. In presence of an higher frailty index, people has a gap between their biological and their chronological age, with a biological age that can be higher than the chronological one in presence of frailty elements. Certainly, frailty has multiple contributors. Sarcopenia, so the loss of muscle mass, is one of the main, with also reduced nutritional intake, the low physical activity level of these patients, as well as burden of cardiovascular and non-cardiovascular comorbidities, cognitive impairment, and also abnormalities, for example, of the mood, with depression, anxiety being prevalent. Certainly frailty overlaps, but is a distinct entity from all these elements, from comorbidity, depression, poor quality of life, and so on. A clinically useful definition of frailty includes slowness, weakness, low physical activity, exhaustion, and weight loss. It is important to remember that there is a vicious cycle of frailty. Patients get worse and worse every day because of this vicious cycle that starts with sarcopenia, undernutrition, and that is continuously enhanced by the reduction in activity, in the resting metabolic rate, in the total energy expenditure that continuously worsens the situation. So disability and dependency are every day more important in these frail patients. considering frailty and the other multidimensional aspects that are related to frailty, we can use different tools, several tools to assess our patients from all these the different points of view. For example, we all know the mini mental state examination for the cognitive function and many other scores and indexes for the different functions we have to assess. For the physical function, there are several scales, several tests we can use to assess and measure the physical frailty. For example, the 6-minute walking test is useful also in this case. The timed get up and go test can be useful to assess patients with limited physical activity and so on. There are also frailty indexes based on the deficit accumulation. All these scores use an approach wherein a number of deficits in a patient are added up and then divided by the total number of variables assessed to give a number between 0 and 1, so to give us a frailty index score. A higher frailty index score indicates worse frailty. A simple tool that we can use to approach and assess the frailty in everyday clinical practice is that the one that is the one that is connected to the simplified Fried criteria that is an evaluation on 5 points, the main points of the frailty syndrome. So we will assess the presence of unintentional weight loss, the presence of exhaustion of physical activity, the work time and the grip strength of the patient. Certainly, frailty is very important in cardiovascular patients because it is one of the main prognostic determinants for this population. Frailty is a state of vulnerability that carries an increased risk for adverse outcomes, so it correlates to medical outcomes in elderly and having a prognostic value for patients with CAD after cardiac surgery and in presence of heart failure and so on, so with an increased risk of death, disability, rehospitalization, prolonged length of hospital stay. Certainly in the chronic cardiovascular disease, the acute events have a great prognostic impact. Here we can see the difference between stable patients and unstable patients, and this is particularly true for frail patients. Individuals who have a lower functional capacity and fewer physiological reserves certainly are at higher risk for homeostatic disruption with stress, with these stressor events, these acute events such as acute myocardial infarction, heart failure, and cardiac surgery. Acute events are points, time points in the history of a patient characterized by fear, anxiety for the patient and also for the doctors, particularly when they have to treat frail patients, and many times the decision after an acute event is to stop the patient, to stop his activity, but to stop is not always the right choice after acute events. We all know the importance of exercise-based cardiac rehabilitation after cardiac events. Cardiac rehabilitation has a robust evidence base demonstrated that it reduces mortality and morbidity in patients with coronary artery disease, with heart failure. So we have in the demonstration by many studies that it is an important intervention with a prognostic impact for our patients. And cardiac rehabilitation has also the ability to improve the quality and productivity of people's lives. Here on the left, you can see how even a mild improvement, functional improvement, is associated with an improvement, for example, on the emotional and aspect of the patient, with the decrease in depression. Also, on the right, in the table on the right, we can see the social, emotional impact of cardiovascular rehabilitation. This is true also for frail patients. Frailty levels certainly improved with cardiac rehabilitation. Higher frailty levels certainly were associated with an higher risk of dropout from cardiac rehabilitation programs, but as we can see in the table here, but certainly finishing the program was related to improving frailty levels, especially in patients who were the frailest. We can see in the three graphs in the upper part of the slide how the patients with the higher frailty index at the admission improved more than the patients with a lower frailty index at the beginning of cardiac rehabilitation. Also, the figure in the lower part of the slide shows the large proportion of patients with large and moderate improvement in the class of patients with a starting higher frailty index. These are data from our unit. We have studied more than 1,400 patients admitted for cardiac rehabilitation after valvular surgery. We aimed at identify predictors of functional recovery with exercise-based cardiac rehabilitation, and we find that the worse the patient, the greater was the benefit of cardiac rehabilitation. Certainly, cardiac rehabilitation is not only exercise, is a comprehensive intervention, is the sum of many activities that at different levels, physically, mentally, socially, give a benefit to our patients. Here we can see the same components of the frailty syndrome we have seen just before, and we can see how cardiac rehabilitation is beneficial for all of them, for all these points. There is an improvement in muscle mass and strength, an improvement in the level of habitual activity of the patient, in the endurance for their cognitive performance, and so on. So in the end, also in the survival and the quality of life of the patients. Here also more in detail all the improvements, the benefits we can obtain with exercise-based cardiac rehabilitation in frail patients. So we can see many point of view, many issues, many aspects of the frailty syndrome can be improved with exercise-based cardiac rehabilitation. Some details about exercise training and frailty. So certainly frailty is bidirectional, and with an appropriate intervention can be reversed or at least stopped if we can break the vicious circle we have seen. Exercise certainly is an effective strategy to prevent and treat frailty, as it can target weakness, low physical activity, the reduced motor performance, and the poor exercise tolerance. Frailty is certainly not a contraindication to physical activity, but may be one of the most important indications to prescribe physical exercise. Certainly tailoring exercise training is fundamental. Tailoring, first of all, means that frailty should be objectively measured, so along with multi-domain scores that give a complete assessment of the patients. For exercise training, at least the 6-minute walking test or a short physical performance battery for more compromised patients should be performed to assess the baseline level of our patients, so to better tailor their training from the very beginning. Another important point to consider is that there is the need for a multi-component program, as we will see in the ensuing slides. So following the FIT scheme that is used for the prescription of exercise, we can see now some more details. F like frequency, so the optimal frequency for multi-component training is 2-3 times per week. Less than 2 times will likely not improve fitness. Greater than 3 times per week may cause that some individuals become overtrained, and so they may lose interest in following the program. It is important to progress the exercise frequency toward the upper end of the recommended range to facilitate the positive behavioral modification. Like intensity, so at the very beginning, certainly particularly while hospitalized, frail patients should be targeted for early mobilization as well as for protein dense nutritional support. Using scales and scores to have more quantifiable measures of intensity is important, including the use of O2 consumption, heart rate, or the rate perceived exertion scale, like a Borg scale. Significant limitations at the 6-minute walking test should be addressed before beginning an aerobic exercise program. Aerobic exercise should start at low moderate intensity, but eventually progress to a more moderate vigorous intensity according to the capacity of the patient. The optimal duration for each exercise session is between 30-45 minutes for frail older adults and 45-60 minutes for pre-frail adults. Certainly, clinicians should adjust the exercise duration to the individual's baseline capacity, and that is dependent, first of all, on frailty status and age. It is important also to consider to remember the long-term commitment, as frail older adults can rapidly lose fitness gains upon exercise cessation. The last type, the type of exercise training. As we have said, a multi-component exercise program is the most effective intervention for improving fitness in frail and pre-frail older adults, because frailty impacts on multiple physiological systems simultaneously. So aerobic training, for example, step-up variation, there's marching in place, or stationary cycling, treadmill exercise, and so on, according to the capacity of the starting capacity of the patient. The resistance training should stimulate and simulate daily functional tasks, such as the movement of sitting to standing, and include a variety of both upper and lower body exercise. Emphasis should be placed certainly on lower body muscle, because this contributes to gross mobility and to the physical independence of the patients. So this is a most important, an important target for the training, the exercise training, particularly for the resistance training. Balance and flexibility training as well. Balance training includes several exercise stimuli, such as line walking or standing on one leg. Certainly close monitoring is mandatory, but balance training is very important to reduce the risk of falls, especially for pre-frail individuals. So balance training as flexibility training could be performed after other parts of the training as a part of the cool down period, or integrated in other modalities of exercise. Flexibility training is very important. For example, it's important for the improvement of hip range of motion, since this is important to reduce peak hip extension negatively impacts stride length and walking velocity, which are factors important to gauge quality in older adults. So exercise in cardiac patient in the form of exercise-based cardiac rehabilitation is safe. Why? Because with an adequate initial risk stratification and the proper tailoring of the activity, we can define the right activity, the right patient for the right place for the right patient. So this is very, very important to have the best work for best and safe work for our patients, our cardiac patients. Cardiac rehabilitation is also cost effective, so all this training, all this multi-dimensional, multi-component intervention positively impact on prognosis of the patient and also on healthcare costs, even in the modern era, where we have many other but most costly intervention that we can use. So these are the main reasons why cardiovascular rehabilitation have strong recommendations from many guidelines. Certainly we have to remember some important limitation to cardiovascular rehabilitation and to exercise in cardiovascular disease patients. First, availability. Globally, availability of cardiac rehabilitation is very, very limited. It's very limited also the referral of cardiac patients to cardiac rehabilitation programs. And last but not least, adherence of the patients to cardiac rehabilitation programs is an important point, because many patients give up, many patients interrupt prematurely cardiac rehabilitation programs. So many efforts should be made at the individual and at the institutional level to overcome all these problems. And also the use of particular modalities, alternative modalities of cardiac rehabilitation are important to help patients in attending their exercise-based rehabilitation program. For example, patients who have difficulty in attending a center-based cardiac rehabilitation program because of, for example, problems in reaching a facility should be referred to a home-based cardiac rehabilitation program. So to conclude, we have seen that cardiovascular epidemiology is changing towards older people who are more likely to be frail and have greater comorbidities. So frailty should be assessed and factored into clinical decision making. Certainly, exercise-based cardiac rehabilitation is beneficial even for frail patients, and improving frailty levels is particularly evident in those who are the frailest. Frail patients should be, for these reasons, prioritized for referral and early initiation of cardiac rehabilitation, and for them tailoring exercise training and offering a multi-component program is certainly fundamental to maximize the outcomes, the expected outcomes. So this is all. Thank you very much for your attention, and see you next year.
Thank you, Dr. Maranta. This has been very informative, breaking barriers to the lower limit of applying exercise. This is useful because, as we understood throughout the day and we understand the next few days, even a little exercise is better than nothing. And that's the great advantage. It is with pleasure that now we give the floor to Ms. Aditya Paramestandini from Indonesia. Hope to say, have said your name correctly. She has an interesting abstract presentation that combines technology and rehabilitation in cardiac disease. The title is Feasibility of Home-Based Rehabilitation and Additional Threshold Inspiratory Muscle Training in Valvular Heart Disease Patients. The mic is yours, Ms. Andini.
Good afternoon, professors, doctors, ladies and gentlemen, all of the participants of 5th World Conference on Exercise Medicine 2021. Thank you for the time. It is an honor for us to present our research, feasibility of home-based rehabilitation, and additional threshold inspiratory muscle training in valvular heart disease patients. Valvular heart disease patients commonly have lower exercise workload and functional capacity. There are some reasons. The first is because of the deconditioning, because of skeletal muscle weakness, because of dyspnea. And for dyspnea itself, it can be caused by inspiratory muscle weakness. However, functional capacity holds a prognostic value in patients with heart disease. In our center, in Dr. Karyadi General Hospital, more than 100 patients of valvular heart disease waiting for operations per year. Our surgeon performed 2 until 3 operations per week. Therefore, while waiting to be operated, or for patients who reject operations, it is important for us clinicians to tailor rehabilitation program in order to improve or to maintain patients' functional capacity, as the lower functional capacity means the higher risk of mortality and morbidity. However, not all of the patients can access cardiac rehabilitation center. In our place, Cardiac Rehabilitation Center, located in the capital city of Central Java. This is in Semarang. We have these patients from all over Central Java, from these beautiful islands of Karimun Java, for example, located 130 kilometers from Karimun Java to Semarang. Patients need to go by ship or by plane, which is not every day because of the weather. And for another rural area, it is also uneasy for patients to go because of the distance, because of the cost, because patients cannot leave work or family. And home-based rehabilitation provides solutions for this problem. Thus, the purpose of our research is to investigate feasibility of home-based rehabilitation and additional threshold inspiratory muscle training in valvular heart disease patients. This is the methods. 18 valvular heart disease patients with age 24 until 53 with heart failure, New York Heart Association Class 2 and left ventricle ejection fraction 65.69% were divided into 2 groups. The first is control group. In control group, we give patients home-based rehabilitation consisted of moderate intensity aerobic exercise and breathing exercise twice a day. In intervention group, we give additional threshold inspiratory muscle training. Control group and intervention group follow the program for 14 consecutive days. This is the prescription. For the aerobic exercise, the frequency is 2 times per day with the intensity rate of perceived exertion 4 until 6 or moderate intensity. First, we familiarize patients with work scale, and 4 times is 10 minutes for each session, and for the type is walking. For breathing exercise, we give 3 times per day breathing exercise. Each session of breathing exercise consisted of 10 respiration with inspiration 2 seconds and expiration 4 seconds. For the method is first lips breathing. And for the threshold inspiratory muscle training, we give the frequency is 2 times per day, with the distance between frequency is 8 hours at least. So patients determine the time when they want to do the threshold inspiratory muscle training, and it's always be the same every day. For the intensity is 100% of 10 maximum repetition. This is our limitation. Commonly, we use micro RPM to measure the PI max of the patients, and then we measure the intensity of the exercise from that PI max. However, we cannot afford micro RPM, so we determine the intensity using maximum repetition. And for the time is 10 minutes. So patients do threshold inspiratory muscle training, the respiration for 1 minute, 2 seconds inspirations, 4 seconds expirations, and then patient rest for another 1 minute. And then after that, patients repeat the training for 1 minute and rest again for another 1 minute. That's for 10 minutes. And the type is inspiratory muscle training. This is the video of the exercise.
Siklus dimulai. 1, 2, 1, 2, 3, 4.
We give this video to the patients,
1, 2,
and
3,
patients just need to
4.
follow the video.
1,
We already
2,
counted for them.
1, 2, 3, 4. 1, 2, 1, 2, 3, 4. 1, 2, 1, 2, 3, 4.
We count for inspiration and for expiration.
1, 2, 3, 4. 1, 2.
If patients feel tired, they can take a rest. Or if they decided not to continue the exercise, they can stop.
3, 4. 1, 2, 1, 2, 3, 4. 1, 2, 1, 2, 3, 4. Istirahat.
After a minute, patients took a rest for another 1 minute.
Selama 1 menit.
And then after that, we repeat the exercise. We improved the prescription, the intensity for the threshold inspiratory muscle training per week when patients came to control at the hospital. For the results, all of the patients completed the program. There was no dropout of the patients in our research. The adherence of home-based rehabilitation and additional threshold inspiratory muscle training was 100%. We followed up patients via video call twice a day, when we also provide patients with training diary. So we give this diary consisted of the instruction of the training and also a table of checklists and patient schedule, the date, and they also need to put some sign of their caregiver. So the caregiver control patient's training when at home. Before and after the program, we measure patient's 6-minute walking test, spirometry, and echocardiography. So the conclusion, home-based rehabilitation and additional threshold inspiratory muscle training is cost-effective, safe, and feasible in valvular heart disease patients. Patients' adherence was good. Follow-up using video call was accepted. However, larger research in this field is needed. Thank you, professors, doctors, ladies and gentlemen. We are grateful for any comments or advice for our research. Good afternoon.
Thank you very much, Miss Dr. Andini. It was very interesting. That's the demonstration that we can do more. It takes just a little technology, and the medicine arena has been underestimating until the recent year, the COVID pandemic, the power of video communication and using little small tools. My question very briefly is, do you plan to go forward to extend the number of patients or to other areas, or take patients that are a little bit sicker?
Thank you, Professor. Yes, we are really look forward for this. We have a lot of valvular heart disease patients in our hospital, not only valvular heart disease, but also CABG. But we really hope we can look forward to this in a larger research in a longer time, because it's only 14 days. Perhaps we can do it more, and we can look, is there any long-term effect of this? Thank you, Professor.
Very well, very well. Very interesting work. There is a quick question in the chat box that I read for you from Rashevaran Kalayazan. Sorry for mispronouncing your names. Does inspiratory muscle training improves diaphragm muscle strength? And if there is any way to measure diaphragm strength?
Thank you very much, Doctor, for the question. Yes, it is hypothetically improve diaphragm muscle strength. I read that to know whether or not it can improve diaphragm muscle strength, we can use USG. However, we do not have that device yet. So, but yes, you can check that with USG. Thank you very much.
I agree with you. One possible way to check the thickening, the improved thickening and the excursion of the diaphragm could be ultrasound through the liver, which is something that has started around. So I think the time has come up. Thank you again for this interesting presentation, Ms. Dr. Andini. And there is another question. How do you check patients do the exercise as you teach? And this is the key question in remote exercise. A quick answer.
Thank you very much, Doctor, for the question. Yes, we did video call twice a day. So every time the patient do the exercise, we video call them, and we also need another supervisor at home, caregiver, family, and we need them to put their sign. But yes, we did video call to the patient twice a day, and surprisingly, patients are very happy with that. They are very happy with that.
I do agree. While the coordination room is putting up the tomorrow schedule, I just read and reply quickly what type of exercise should avoid during cardiac rehabilitation. And I think you have to assess the patient, whether he has an ischemic threshold or anything that will increase too much his workload. So not every patient in cardiac rehabilitation is the same. I think you agree to give this reply to Dr. Zubair Qureshi. Thank you. If the coordination room and the video coordination have been excellent, so I wish to thank all the team. Maybe you've noticed that we had a little glimpse, but I don't think you saw it before. So this is great work. Thank you to Dr. Lee, thank you to Dr. Sri Lai for having us keep working together. So the screen is for the next sessions. Thank you very much. See you soon on this video and hopefully on live.
Thank you, Professor.
Your love is your own now, so just keep up your feet and don't stop running. Lift up your heavy limbs to the sky. I hear your heart beating ever so fast. Don't you dare let it stop. And all the nation together as one, fighting for a brighter future, inspiring all the new generation. Here is where we stand. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, let your steps pick the way for the future. 'Cause you're alive, inspiring others. Don't you lose your hopes due to hurt and loneliness. 'Cause there's always another way. And all the nation together as one, fighting for a brighter future. Gathering all our brothers in arms, here we will stand tall. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Just keep moving. Just keep moving. Just keep moving. So just keep moving and don't stop for anyone or anything. Just stay strong. Your life is your own now, so just keep moving. Oh, yeah. Pick up your feet and don't stop running. Lift up your heavy limbs to the sky.